I welcome you all for this webinar, the first of the new committee. This is a topic which is a little offbeat, uh, more of practical rather than academic, then and now. So, what used to happen, everybody of us have been practicing for many years and have their own experiences and have their own anecdotes. Today, we'll be hearing from all of you about what has been done before and what is happening now, more about individual practice, group practice. So, I also welcome Dr. Balaji, sir. Good evening, sir. He
Thank
will
you,
be
sir.
talking on group practice.
Yes.
So, I hand over to Dr. Priti Dixit to continue, who will be the MOC for this session today. Dr. Priti, please continue. Thank you, everybody.
Good evening, everyone. I welcome you all from the behalf of ISA Borivali. This is the first webinar of our Scientific Committee 2025 and 27. As our theme suggests, old and new in anesthesia, we are here to listen to our esteemed speakers, how they have evolved over the time, embracing both traditional and modern techniques. Am I audible, na?
Yes,
Hello?
yes,
Yes.
yes.
We are here to learn, unlearn, and relearn our all ever-changing landscape of medical science. So we start with our first topic, that are the blocks. Blocks, as we all know, we have started learning with the anatomical blocks. Then we have progressed to PNS and USG guided blocks. So I welcome our first speaker, anatomical guided blocks, Dr. Jinal Solanki Shah. She has done her MD anesthesia from Nair in 2014. She is a freelance anesthesiologist at Macabo area. We fondly call for the Malad, Kandivali and Borivali area since 2016. She is majorly doing ortho cases. So she is the apt one to talk about the topic on the anatomical guided block. And apart from all these academics, she is a very good singer. In all our gatherings, she will have lots and lots of songs to sing for us. Welcome, Dr. Jeeral. Over to you.
Thank you. Yeah, so I'll share my presentation. Good evening, everyone. So just a minute. So my topic is simple yet so it is anatomical or landmark guided nerve blocks. Everybody, as Dr. Preeti mentioned, started with this. I am still practicing it probably because I've got comfortable with this. And I'm doing this on the regular basis with the help of my team. Just a minute. So the blocks I commonly practice are the upper limb blocks, that is the interscalene, supraclavicular, transaxillary, and lower limb I do femoral, adductor canal, popliteal, fascia blocks, fascia iliaca block most commonly. So why I still do it, and why you can consider it too, though just a minute, I can't. Oh no, wait. I'm not able to get my presentation. Wait. Where is it? Here.
You are able to see it, Jinal.
I can see, but there's a thing coming in the sides. I'm not able to make out what I've done. So why I still do it and why you may consider it too. So most commonly everybody is doing USG and PNS guided blocks now. But still there is knowledge required for landmark guided block because first of all, sometimes when you're in the hospitals, there can be a failure of technology. USG machines can malfunction, or it may be unavailable in low resource settings, and there will be problems related to PCP and DT also sometimes. The PNS that we use may run out of battery, may malfunction, or the stimulus needles may not be available sometimes. This is a very cost-effective method because there's just a syringe and needle required. And there is reduced complexity because you have to get familiar with the PNS guided blocks, USG guided, you need to learn the techniques. But this is very simple. And if you have a good knowledge of landmark guided blocks, the other PNS guided and USG guided becomes more successful. It's not going ahead. Wait, yeah. So how do I do it? Obviously, the PAC is done with emphasis on medications like blood thinners or allergies, if any. Informed consent is obtained, and before the patient identity is please confirm and patient is taken to the OT, and we explain the patient that the amount of cooperation required, because we are doing mainly paresthesia guided blocks. So exactly what is expected from the patient is explained to the patient, and the patient is prepared mentally. So pre-procedure, we have standard monitoring, that is cardiograph, NIBP, pulse ox standard. We confirm patent IV access. We confirm whether there is adequate space around the patient and to give the block and the position required according to the block. Sterility is to be maintained. I commonly use 0.5% bupropion, 2 mg per kg dose. 20 cc syringe is loaded. Also, lignocaine occasionally when I need to give a volume, and dexamethasone is added in all my blocks with 8 mg per kg for adults, and in children 0.15 mg per kg dose according to the weight. So I am commonly using a 24 gauge, that purple needle, a small needle, and syringe always attached while giving the block. So with the same, when we are injecting, we inject the same drug around the skin at the entry point to numb the skin, and the block is given. Always we consider light sedation to allay anxiety with patients are anxious, and there's sometimes positional discomfort, so it is better. Not always, and this is done after confirming the block is acted well. Okay. So the upper limb blocks, commonly, the first is the interscalene. Most commonly given is a gold standard for shoulder surgeries. Patient is positioned with the head turned to the other side. You feel for the sternocleidomastoid both heads, the sternal head and clavicular head, and go laterally for the interscalene groove, which is present between the anterior and middle scalene muscle, and just at the level of precoid, which is the C6 level, making a line perpendicular sort of. You enter the needle. The needle is entered aiming in the downward and medial direction. And we elicit the paresthesia in the C5 dermatum, that is the shoulder region. So when the paresthesia is elicited, we give the drug. Okay, so sometimes you may encounter the transverse process or something. So you just have to walk over the transverse process, and when the patient gives paresthesia, again, you give the drug. And the next is supraclavicular block, very commonly practiced. Here you can see the anatomy. It is passing just above the clavicle and over the first rib, the first rib here. So again, the position, okay, we are positioning the patient with head moved laterally and arm a bit lowered, so that we can have the nerve bundle not moving. So the patient is turned to the other side, arm is slightly pulled down. Feel for the sternocleidomastoid, both heads, and just lateral to that, 1.2 centimeters lateral and above the clavicle. We direct the needle medially, posteriorly, inferiorly. Again, we try to elicit the paresthesia over the fingers mostly. Sometimes there will be a sparing or something. You have to walk the needle a bit. After administering 10 ml of drug, you change the direction, and we are using a very small needle. So we are not having a very big angle when we are moving the needle. So sometimes you may hit the first strip, and you can administer the rest of the drug there, because the drug spreads to the other nerves as well. The next is transaxillary block. So yeah, here we are asking the patient to lift the arm in the right angle, or completely up in the Statue of Liberty position. It is used. Sorry, somebody's talking. So these usually target the terminal branches of brachial plexus surrounding the axillary artery. within the neurovascular sheath. The axillary artery is the main thing which is palpated against the head of the humerus. You feel for the artery. There are three nerves here. The median nerve, which is traveling superior or say anterior to the artery. The ulnar nerve, which is traveling medial or inferior to the artery, and radial nerve is posterior. So you punctured, you ask the patient to be supine with head, with arm abducted 90 degrees and elbow flexed. That is Statue of Liberty position. Locate the axillary artery. We use a short bevel needle which is directly aimed at the pulse. When you have a bright red blood on the hub, you advance the needle further. That is where the patient may sometimes complain of paresthesia, illicit paresthesia. You may administer the drug, and we again withdraw the needle a bit and just again always aspirating, negative aspiration for blood. You go above and below the artery and administer the rest of the drug. We withdraw. So this is just about the upper limb blocks. Now the lower limb blocks. I'll start with fascia block because that is where we start with. The hip surgeries, a patient having fracture neck femur and all, to make the patient fit up for spinal also, we are giving the block prior to spinal. So fascia ilaka block is given usually here. You palpate for the ASIS and the pubic tubercle, and you divide the line into three parts. So the junction of the first lateral 1/3 and medial 2/3 is the place just above the inguinal ligament. 1 centimeter above the inguinal ligament is where you inject the needle. We blunt the needle usually in the DEXA syringe or DEXA ampule, and you get 2 pops when you inject it. The first is the fascia lata. Here you get a first pop of fascia lata and the second pop of the fascia iliaca. And here you have 3 nerves. This is showing femoral. Here you have lateral cutaneous nerve of the thigh, obturator nerve. All the 3 nerves are bathing inside the anesthesia fluid that we're giving. So it is usually primarily a pain management block. It is not for anesthesia because the nerve supply to the hip is complex, multi-source. Single nerve block often provides incomplete anesthesia, but excellent anesthesia. It is a gold standard for preoperative pain management in neck fracture, humerus, and postoperative anesthesia. So these are the 3 nerves that we encounter. So femoral block, again, here again you feel for the femoral artery just below the inguinal ligament. And 1 centimeter lateral to the artery is where you inject. Your patient positioning supine with legs externally rotated. In obese patient, we usually retract the abdominal fat to make space. Even for the fascia ilaka, we are doing the same. We obviously retract the abdominal fat. Insert the needle 1 centimeter lateral and cephalad to the femoral artery. We feel for the pulse at the inguinal crease, and patient may give response in the form of paresthesia around the thigh and knee, and the drug is injected very slowly. The adductor canal block, which is a sensory block used to manage pain after knee surgeries. We are always giving all the blocks prior to surgery because in case there is extension of the spinal time, we having that coverage as well. So highly valued for its motor sparing effect, which allows for earlier mobilization and reduces risk of fall. Key anatomy, we have the vastus medialis anteromedially and the vastus adductor longus posteromedially, and sartorius, which is on the lateral border. So you feel for the sartorius. Okay, the nerve you're targeting is saphenous nerve. You feel for the sartorius. There's a whole 10 centimeter canal called the Hunter's canal usually. So in the at the mid-thigh level, you have the nerve which is laterally placed. As you go distally, it is going more medially and posterior. So if you give just about the mid-thigh level, you direct it laterally in the adductor canal, aim for the blood. Usually the femoral artery is traveling along with it. Most of our nerves are traveling along with the vessels. So it is when we have blood at the needle hub, it is suggestive of the we give and we sometimes have paresthesia, and we give the block. We may need to go more medially as we go distally towards the thigh. So popliteal block we are giving just below the knee. Aim is to block the sciatic nerve, which descends into the popliteal fossa, most effectively administered at or just proximal to the bifurcation of sciatic nerve. So there is a popliteal fossa. The split occurs 5 to 10 centimeters proximal to the popliteal crease. So boundaries, we have the biceps femoris tendon on one side, and the other side is semimembranosus and semitendinosus. You, as a patient, we with the help of a helper, we flex the patient's knee. Leg is lifted, held with the knee belt at 90 degrees. Direct the needle towards around at the apex. You go around 7 centimeters from the proximal crease, and there you feel a loss of resistance, and that there is where we inject the drug. And this is you can just do our surgeries of the lower leg in this along with the saphenous nerve, which is usually missed. So for saphenous nerve, we of the branch of femoral nerve, which is providing the sensation of middle aspect of leg and ankle. It originates from the okay. This requires a separate saphenous nerve block for complete anesthesia. Sorry. For this, we usually inject around 5 ml subcutaneously just in the anterior middle aspect of the knee, just above the femoral condyle. So that is how I do it, and thanks for patiently hearing.
That was very nice presentation, Vinal. Question answer we may take at the end of the session. But all these blocks you do in awake patient, yeah, along with GA.
Awake patient, we need patient cooperation for paresthesia. We usually ask the patients for paresthesia, and that is how we administer. And that ensures a good block when we have patient cooperation and paresthesia elicited.
We started, but we have not practicing now anatomical blocks. We have moved forward, but it is good to listen. You are still practicing anatomical, the basics. Thank you for the nice lecture. Now we move forward for the PNS guided block. For this session, we have our senior consultant, Dr. Rajiv Garudkar. He is having 37 years of anesthesia experience. He was a consultant neuroanesthesiologist at he was consultant neuroanesthesiologist at Nanavati Hospital. At present, he is attached to Karuna Hospital. Sir has pain management fellowship from AIM, and sir special interest area are neuroanesthesia, nerve block, pain management. He is very keen in managing high-risk cases. Apart from academics, sir has been held a degree in Sangeet Visarad of Indian classical music, and sir is very much enthusiastic marathon runner and very much loves cycling. Welcome, Rajiv Garud, sir. Over to you for PNS guided block.
Good evening, everybody. I'll share my screen. Is my screen visible?
Yes, sir.
Okay. Today's topic is PNS guided blocks. Regional anesthesia always works, provided you put the right dose of the right drug in the right place, said by Dr. Denny Harp. Historically, nerve blocks were performed using anatomical landmarks as a guide to where to insert the needle and then eliciting paresthesia. Multiple attempts to elicit paresthesia, which was perceived as painful, failure rate of nearly 20%, and fear of neurological sequelae prompted search for safer guidance. The advent of peripheral nerve stimulation and later ultrasound guidance have sought to add an objective endpoint to aid nerve location. So basically, what we need for blocks is accurate nerve location, and peripheral nerve stimulator satisfies that need.
सर फुल स्क्रीन करा ना.
फुल स्क्रीन कसं करणार? I don't know how to expand it. Are you able to see the screen? Read?
Slideshow वरती जा, slideshow वर. Right side.
हाँ, right side slideshow. हाँ.
Okay.
Yes sir.
Okay.
Yes sir.
Yes.
History in brief. In 1780, Galvani first described effect of electrical neuromuscular transmission in frog. In 1912, von Perthes described a selective nerve stimulation. 1955, Pearson introduced concept of insulated needle, and 1990, proper use of PNS for nerve block. So it took around 200 years from the description of electrical neuromuscular transmission to proper use of PNS for nerve blocks. So the evolution was very slow because of lack of insulated needle, and even after insulated needle, it took so many years to achieve peripheral nerve stimulator guided blocks. Before that, electrostimulation was used for temporary pain relief, blocking the painful nerves. Now, classification of peripheral nerve blocks. Peripheral nerve blocks can be truncal blocks like tap block or paravertebral block. Then intercostal block also is a truncal block. Plexus blocks like brachial plexus, lumbar plexus, sciatic plexus, or sacral plexus, or distal blocks like individual nerve blocks, and field block like a hernia block and topical block. These are the images of peripheral nerve stimuli. These are this is a very old model. Then one on the right side is a modern model. This is also a very old model, and this model most of us we are using. This current range is from 0.1 to 6 milliamperes. Current is a linear and constant current, low output. Pulse frequency is 1 Hertz for mixed nerves and 2 Hertz for sensory nerves. Apart from nerve blocks, we can use PNS for pain management and injecting pain relieving drugs either temporarily or for longer duration like alcohol or other drugs. So PNS can be used for that. And these are the nerves like median ulnar radial neuropathy can be accessed with this. Occipital neuralgia can be treated. Cluneal nerve pain, pudendal neuralgia, femoral sciatic obturator neuropathy, brachial lumbar plexus neuropathy, meralgia paresthetica, lumbar or cervical radiculitis, and intercostal neuralgia. Now, most of us are using peripheral nerve locator. Initially, when I graduated from Grand Medical College, we were using only anatomical blocks. No nerve locator was there. After starting private practice, I came across peripheral nerve locator, and for more accuracy, we started using peripheral nerve locator. And since then, till date, I am using peripheral nerve locator regularly for blocks. I do not give anatomical blocks. So to give a block for any nerve, initial stimulation should be current up to from 1 to 2 milliamperes, pulse duration 0.1 millisecond, and frequency 1 to 2 hertz. After setting this on a nerve locator, we start stimulating the desired nerve or plexus with the stimuplex insulated needle, and current is gradually reduced and needle advances slowly once sought after muscle response is obtained. Now muscle response should be obtained at the threshold 0.2 to 0.5 milliamperes at 0.1 milliseconds. Once this desired response is obtained, we aspirate, then give a test dose of 1 to 2 ml of local anesthetic injected. This abolishes muscle twitch. Then we increase the current to the initial level. If there is no stimulatory response with the increase in current, then we inject the remaining drug, frequently aspirating for any blood, looking for any blood aspiration. Failure of the twitch to disappear, or pain on injection, or there is high pressure while injecting. This suggests intraneural placement of the needle tip and warrants small withdrawal of the needle tip, and then confirm and inject again. Commonly given blocks are for brachial plexus, supraclavicular, infraclavicular, interscalene block, axillary block, and for lower limb surgeries, I give lumbar plexus, sciatic, popliteal block, and sometimes ankle blocks also. So the technique and twitches, muscle twitches, and all everybody knows. The response should be like for brachial plexus, the response should be fingers twitching and not the elbow or biceps. Finger either extension or flexion. Or sometimes we get lumbrical muscles contractions also. And for lower limb, for quadriceps, for lumbar plexus block, quadriceps contraction, and for popliteal and sciatic block, muscles or calf muscle contraction. In contraindications for giving nerve block, allergy to local anesthesia drug and patient refusal are absolute contraindications. Relative contraindications are coagulopathy, patient receiving blood thinners, and local site infection. How to prepare for a nerve block? Before any nerve block, please check functioning of the nerve locator, which is very important. Check battery or adapter is working. Check all wires and connections are in proper position. Check proper size of the needle and check required drugs. Now, why I use PNS and what are the advantages of PNS? That is the main topic of today's discussion. PNS is a very simple instrument, a compact instrument, a small instrument, easy portability, especially useful for freelancers because we have to visit different nursing homes. And most of the nursing homes are not very well equipped, or they don't have gadgets like ultrasound machine. So this is the most useful tool to administer block in a nursing home. Even for peripheral, those who practice at the district places or smaller places like villages where, or not exactly villages, but nursing homes nowadays in villages are also common, but they are also not very well equipped. There you can carry your PNS and give blocks. Then it is free from regulation as for ultrasound use. You all know that especially in Maharashtra or all over India also, the rules and regulations for using USG machines are very strict, very complicated, and so many parameters are there. So this PNS is free from all those things. Cost effective is the lowest cost of equipment used for nerve blocks. and less expertise is required. For blocks, and compared to blocks under USG, you need a lot of experience, a lot of expertise. You have to learn the technique properly, how to visualize the nerve, where to exactly inject, how to locate your needle. All that needs proper teaching, guidance, and experience also. Comparatively, nerve locator needs less experience. And accuracy is concerned more than anatomical or paresthesia method, which is much more accurate, PNS. Main advantage is we get objective feedback. Like patient may or may not cooperate, but he cannot alter or hide the twitch response. So twitch response is an objective feedback, and once it is obtained, it is a most reliable.
Sir, you are not audible. Garud sir. Hello, Garud sir.
I think Garud sir is not in network. He may join soon, huh?
So we go ahead with the next topic.
Just wait. I think he's joining. I'm trying to connect to him.
Meanwhile, Dr. Jinal, are you there? Hello,
Yes.
Dr. Jinal.
Yes.
What is the failure rate? The question is there.
Yes, I saw that. Yeah. So I can say that I have been 90 to 95% successful. There could be some sparing sometimes, which we manage with sedation, and sometimes maybe we repeat the particular area block. Mostly, I've seen ulnar nerve areas are usually less anesthetized. So we either repeat it if you're giving supraclavicular, we try to elicit paresthesia in that area, or transaxillary. Again, we try to elicit the paresthesia in the ulnar nerve area.
Hello?
Around the last two fingers, and we are able to manage.
Repeat supraclavicular with the dose.
The dose, maybe 10 ml more of the dose. Usually I'm 20 cc of dose for supraclavicular, for interscalene, for transaxillary, everywhere. So 10 ml more we will try to inject.
Okay, I'll get back to you again.
But we usually, like if you are giving bupivacaine, I will try to add a bit of lignocaine as well for the second. I would manage for the dose.
But now they say we should not mix the two drugs. The studies are there.
Not mixed drugs.
No long acting or short acting mixing of the drugs.
No short acting.
No mixture of the drugs. The new study say you stick to one drug only, either short acting or long acting.
Okay. Mostly I'm giving bupivacaine, but sometimes I do add lignocaine to manage for the dose. That I'll just say.
Okay.
Yeah. Less of lignocaine though. Yeah.
Dr.
Garud
Jinal,
sir,
what is favorite additive?
Sorry?
Additive. Which
Additive
additive do
is
you
only
use?
dexamethasone. Only dexamethasone I add. Just dexamethasone for long acting of the block.
Garud sir is there back again, or shall we move ahead to the USG guided block?
I think he is having some network issues. We can start off with the next thing.
Okay. Thank you, Dr. Deenal, meanwhile.
Yeah.
So some network issues has occurred with Dr. Garud. So we move on to our next topic. The next topic is USG guided block. For this topic, we have Dr. Sama Shah. Ma'am is Senior Consultant and HOD Anesthesia Bhaktivedanta Hospital. Ma'am is still in OT. Oh my God. Ma'am has 27 years of experience. She is BLS and ACLS instructor, and she has several publications of national and international journals to her credit. Over to you, ma'am. Welcome you, ma'am.
A very good evening to all of you. Thank you, Preeti, for a kind introduction. At the outset, I thank SAM's office bearers as well as the BSA office bearers to give me this chance to uh, do this presentation. So, already we have heard two speakers. I think Rajiv Garud sir's some presentation we'll hear later. Are you able to see my screen?
Yes, ma'am.
Okay.
Able to see, but you have to maximize it. Full
So,
screen, sir.
yeah. So, what we are going to discuss today is USG guided nerve blocks. It's a vast topic. Of course, I bring greetings from Bhaktivedanta Hospital, and uh, so ultrasound guided USG nerve blocks is a transition from traditional our landmark or nerve stimulator techniques to real time sonographic guidance technique, and it has improved safety, efficacy, predictability of the regional anesthesia. So we have three eras of regional anesthesia. First was the paresthesia era from 1884 to 1960s, where the dictum was there is no paresthesia, no anesthesia. So this was invented for first demonstrated by Halsted and Hall. They were American dental surgeons. They injected cocaine in the infraorbital nerve, and then they elicited the anesthesia. So many years every time, and of course in India, many of our senior consultants we were practicing this paresthesia guided regional nerve blocks, and we will not inject the drug till patient says हाँ झुंझुनी होता है हाथ में, there is a tingling numbness. So that we have witnessed that area, and then came the era of nerve stimulator area where 1962 portable electrical stimulators were available, and then what nerve stimulator basically did it is that needle moved more close to nerve without necessarily hitting it. So it definitely improved safety in sense that the patient would not get any neuropaxia or nerve injury. But still, because whatever nerve blocks or plexus blocks we are giving, generally it's a neurovascular bundle. Vessels are always around it. So when it was PNS guided, surrounding vessels injury chances were definitely more. And then the so-called golden era we all have entered is a ultrasound era, and first ultrasound guided nerve block was introduced by Stephen Kappel team in Vienna, and that basically blindfold was removed in the sense that we were not doing any nerve block now. It's not no blind technique. Everything whatever we are doing is a real time, and real time visualization we can do where the needle is moving, where we are injecting, how much spread is there, everything we can see. So and the future is the artificial intelligence, it is try to get a software where they will just tell us that it can be more color specific. It will be auto identification. We don't have to figure out which is nerve, which is muscle, which is tendon. It will tell us that it's a nerve, it's a vessel, it's an artery, it's a vein, and then smart needles are to be expected, which will have magnetic sensor, and it will really locate nerve very well. So mid 1990s till 1990, all the radiologists were doing all ultrasound guided biopsy. They were using needles and they were taking biopsies. But the anesthetist team in Vienna, they did this first time in 1990, and they performed the first USG guided nerve block, and it has changed the paradigm of anesthesia. So, what are the fundamentals of ultrasound guided guide? So, basically, ultrasound is a device where we have a probe, that's a transducer, and it generates a high frequency sound waves more than generally 20 kilohertz, and using piezoelectric crystals in the transducer. And what happens is that the ultrasound wave propagate through the tissues, as you can see there in the picture. It propagate through the tissue, and then those waves get reflected back to the transducer. And then what the time delay taken place, and depending on the intensity of the returning of the wave, there is a real time two-dimensional image which comes on the screen, and we are able to identify the tissues. Of course, and every tissue has a different echogenicity. By echogenicity, we mean that how much of the sound waves that tissue is reflecting. Depending on that, echogenicity of the tissue is decided. So here, the first picture, we can see this is anechoic or hypoechoic. That means that it's a dark. There is no echo. So what happens is this is for the areas where there are fluids. It can be clear fluid, it can be blood. So what happens is that ultrasound waves are absorbed by these places, and there is no reflection. So it appears dark. And that's what happens when there are blood vessels, there is a cyst, when we have injected local anesthetic agent, and that area appears a anechoic or hypoechoic area. Then there are some tissues. Then we have other tissues like bone, fascia, tendon, muscle, nerve. So they all reflect the sound waves in different intensity and degrees. So depending on that, we get the image on the screen. So bone being most hard tissue, it doesn't allow the sound waves to penetrate at all. So wherever there is a bone, we'll see the very dark. So in the image, we can see that there is this femur is there. So white line, and above is the muscle, and above is the facial planes and muscle. So basically, we can see all that. And now, generally, now is seen if we have a nicely. We are nicely visualizing the nerve, then we can see the round nerve. When it is nicely transverse cross section, we can see a round nerve, and when we are in longitudinal axis, if we are observing the nerve, and it will be nicely, we can see the whole nerve. So of course, the types of probes, we have to be more information we must have. So basically, there are 3 probes, and out of that, we as anesthetists, it's more applicable to us are linear and curvilinear. So linear probe, it has 5 to 20 megahertz frequency. So it is more suitable. It is a very poor penetration, so more suitable for superficial structure. Then there is a curvilinear probe. So how the curvilinear probe sends the sound waves, it gives you more wider footprint, and it reaches a deeper structure. It has a greater penetration, so it reaches a deeper structure. In phase array, not be if we are expert, we are learning focus, then phase array probe is more useful. So after selecting the probe, while we are preparing for giving it the block, the needle we have taken. So this needle we can use in USD guided block by two different approaches. One is in plane by using it long axis, and another is out of plane. So in plane means we are going parallel to the probe, and in plane the advantage is we can visualize the needle tip, we can visualize the full shaft of the needle, and we can exactly know where, when we are manipulating the needle, where exactly we are going. So it has a better degree of control and better degree of safety because it's a whole needle with the tip we can see. While out of plane is a short axis, means uh, you are wanting when we are scanning the structure, when it is out of plane, it's going perpendicular to the waves, to the long axis, and then uh, we will see the needle. Okay, needle is seen as just a tip, as you can see in the picture. So out of plane, we can see that. So there are more chances of getting nerve injury or muscle injury, because sometimes we are not very sure how deeper we have reached or how superficial we are. So what are the advantages of this USG guided block over PNS guided blocks? So first is there is real-time direct visualization. Whatever we are doing, it's there in front of our eyes. Whichever structures, anatomical landmarks we want to make sure it will be there in front of us. And when we are doing USG guided blocks, whenever there is a drug spread, we can see it is going. We can see how well it is spreading, whether it is going inside vessel or whether it is going inside nerve, which may cause the injury to vessel or nerve. So drug spread we can see very easily. Then if every human being, though we have a Gray's anatomy and we have all the structures described, but there are huge anatomical variations, and then that we will realize when you will start scanning different patients. So sometimes there will be vessel will be more medial, sometimes more lateral, and there will sometimes if we are doing supraclavicular blocks, some nerve bundles are more medial, so lateral, though they are supposed to be in one fascia. So PNS guided blocks, when it was not under vision, there were more chances of failure because sometimes some nerve roots or some nerve bundle was missed out. But these anatomical variations can be very, very nicely seen, and then we can put your local anesthetic there. And now the reduced volume of the local anesthetic. That is a very, very great advantage of USG guided block, because whenever I remember when I in KEM we learned landmark technique, or we learned PNS guided. So we used to landmark. So we used to give sometimes 30 ml. In axillary, I have seen people injecting 40 ml of the drug. But when it is USG guided, yeah, the volume has come down to 15 ml, and so many conferences it is discussed. Sometimes they inject just 10 ml, or sometimes only 8 ml, and the successful block is achieved. So that's a very great advantage. We can prevent the local anesthesia toxicity. Then there is a higher success rate and faster onset, because you have put your drug right there under vision around the nerve, and faster onset is also there. Then there is an enhanced safety profile. There's lesser risk of intravascular and intraneural injection. And especially when we are doing brachial plexus block, the lower risk of pneumothorax. Brachial plexus block, infraclavicular block, there is a lower risk of pneumothorax when we are doing USG guided. Plus, when it was landmark or a PNS guided, sometimes we have to search for the nerve, and then sometimes few attempts we have to keep changing the locations. And PNS guided, we have to start with 1.0 hertz milliampere, the current. And sometimes if the patient is very muscular, then the whole arm moves and patients are very uncomfortable. So here when it is USG guided, you can go down up to 0.7, 0.8, and you can perform the block. So the twitch intensity, what you get in the muscle will be very less and patient will be more comfortable. And facial plane blocks, again, it's a new world of blocks where different facial planes we can inject. And when it is USG guided, some facial blocks can be done by just pop of landmark guided, but when it is done with USG guided, it has more success rate. So the list, just to go through the form as a formality, the list: in upper extremity blocks, interscalene block, subclavian perivascular block, infraclavicular block, axillary block, costoclavicular block. Then we can go down and block the individual nerves like median nerve, radial nerve, ulnar nerve, suprascapular nerve block, superficial and deep cervical plexus blocks. All these are performed in upper part of the body. Lower extremity, femoral nerve block, adductor canal blocks, obturator nerve block, sciatic nerve block by different approaches. Then electrofemoral cutaneous nerve block, FICB, PENG block, ankle block also sometimes can be, because you can recognize the artery and just inject around and it will be more successful. Then there's a big list of facial plane block: rectus sheath block, tab block, hernia block, fascia iliaca. These first four blocks can be done by pop-up technique also, but when it's done under USG, you have a higher success rate. Then comes erector spinae. Again, that also sometimes can be done as a landmark technique, and you may. But then subcostal tab block, quadratus lumborum block, PEC 1, PEC 2, and serratus anterior. These have changed the post-op analgesia paradigm. So, and the use of USG machine has a big contribution in the development of these blocks. So how to have a higher success rate? When I first attended conference on USG guided work, first question I asked the faculty was that, is your block acting 100% compared to PNS? So of course they said definitely the success rate is higher. So basically USG guided block is less about hitting nerve and more about image optimization and needle control. And for that, we have to have very thorough knowledge of the anatomical landmarks. And after having thorough knowledge of anatomical landmark, to search that on the patient, we have to keep scanning the patient. More you scan, more you become expert. So when we started a Bhakti Vedanta USG guided blocks, that is almost 9 years ago, when the USG machine became available to us, we used to either keep scanning on ourselves if patient is under general anesthesia, and if some areas are approachable, we used to scan those areas of the patient to get the anatomical orientation. And more you scan, more you'll come to know what kind of anatomical variations can be there, and more you'll be able to recognize your target structures. So to make your block more successful, first and foremost important very golden rule is you have to manage your ergonomics. Ergonomics means where patient is going to be there, where you are going to sit, where is the screen of the ultrasound. So patient injection site, ultrasound screen, and your eyes should be in same line. That is a dictum. If I am sitting on the right side of the patient and I want to do femoral nerve block, the screen should be on the left side of the patient, not on the right side of the patient. Because if it is on the right side, opposite side, then my hand and coordination with the probe will not be, and every time, and hand coordination and screen coordination will not be good. And basically, ultrasound guided block requires critical cognitive motor skill. Your hand-eye coordination is most important. So, your where you're placing the USG machine, where you are sitting, where is the patient, how you are holding the probe. That's most important. And depending on whether you are right-handed or left-handed, again the orientation will change. Then the position of the patient. Some patients, uh, uh, if it is a upper extremity block, if it is interscreening or subclavian perivascular, it is better to have patient in little bit propped up position. Then you can visualize the structure much better and much with the ease. Then very important is the probe selection. So, and what is your probe orientation? Probe orientation means from the side, whichever side your needle is going to enter should not appear on opposite side on the screen. It should appear on the same side of the screen. So then your block will be much easier. Your orientation will be much easier. Then we have to master the part mnemonics. This, if you want to have a successful visualization of the anatomical structure on the screen. So first is there, when you are holding the probe, to give adequate pressure. When you give adequate pressure, then you are reducing the distance between your nerve and the transducer. But before that, we have to make sure that you are not giving that much pressure that you are obliterating the vessels. So you have to check where is the vein, where is the artery. Sometimes if too much pressure is given, vein is totally collapsed and you might just go through the vein and you might injure the vein. Then alignment. So now should be in the center. So many times I see on the screen, now if I am giving subclavian perivascular block, subclavian artery, and the bunch of grapes is on one corner and my needle is entering on another corner, then reaching the needle will become difficult. So get your whatever target nerve is there, get it in the center of the screen first. Then rotate the probe in such a way that you get 90 degrees cross section of your nerve. Then your fascicles and your nerve will be seen very nicely on the screen. Then little bit adjustment sometimes along with that. If you want to see sometime needle properly, then just little bit tilt and you will be able to see needle properly. And the most important is there, the hand should remain very stable. So just like in the picture, you are able to see we have to hold the probe at the base, not at the tip. So if you hold it at the base, your hand will be stable. The probe will not slip while you are performing procedure. And if probe slips, then all your orientation or your visualization on the screen goes away and you have to start again with the scratch. So hold it nicely, hold it at the base and hold it firm. Then after many times what happens is the needle is not fully visualized. So what we can do as inject 1 or 2 ml normal saline. As soon as some fluid goes in the area, needle becomes more prominent, it starts shining and needle tip can be seen better. And it allows your repositioning of needle before the actual local injection of the local anesthetic drug. So especially when you are doing facial pain block, we need to see whether all the two muscles are getting separated. So first we should try with normal saline and see whether in proper place and then inject the actual drug, because the facial blocks are generally a large volume blocks. And focus on the facial plane or not just on the nerve. So what I mean by this, so ensure there is an adequate spread. So suppose I'm giving subclavian perivascular block. So many times I enter the fascia, the sheath, facial sheath. And many times if I have not entered properly, I can see the drug going out and now bundles are not getting soaked. So I have to feel the pop and then see the drug is spreading evenly. Then my block will be successful. Then there's a donut size. So this on the screen we can see there's a femur and this is a popliteal block. You can PA is popliteal artery and above that is a tibial nerve. So when we enter from one side, the nerve the drug is getting injected only on one side, and then I should little bit change my needle direction, go on the other side, and then inject the drug in such a way that whole nerve is surrounded by the local anesthetic drug. So this is required for the 100% action. So that's called a donut sign. If fluid is only on one side of the nerve, reposition needle and go on the other side. Then many times, for example, we are not able to recognize some structures, then start with the proximal scanning. So for an example, if I want to do adductor canal block and how medial is there, I'm not able to locate, then I should start from femoral artery, scan femoral artery and keep following femoral artery down, and come at the mid thigh and lower mid thigh, and then I'll be able to see the femoral artery in the adductor canal, and I will be able to see sartorius muscle as well. So trace the location and then inject the drug. So scan proximal to distal whenever required, and take up help of assistant. You need an assistant for USG guided block because one hand is busy in holding this probe, and with the other hand, I am manipulating my needle, and the person I require a person to inject the drug. I know the all anesthetists are multitaskers. In my PG days, when in KEM, when there were no ventilators, our eyes used to monitor the screen with my in my axilla. I used to keep pressing the bag, so ventilation used to continue. With my hands, I used to break the ampules and inject the drug, and this all of us have done in our PG days. But let's not become multitaskers. When we want to have a successful block, let's take a help of assistant and train that assistant because sometimes image becomes freezed, or sometimes image we need to do some adjustment of the
Sorry to
USG machine.
interrupt, madam. More slides, yeah. Actually, Dr.
I
Balaji
almost
sir,
finished. Almost finished. Okay.
sir has to leave. He has requested thoda
Yeah.
sa.
And we have to know our machine. So
Yeah.
summary checklist is a pre-scan well, identify your landmarks, take appropriate length of the needle, insert the needle 1 to 2 centimeter away from the probe, advance the tip if it has to be visible, use color Doppler if you are in doubt, watch for the pressure while injecting, inject the drug only if spread is visible. So take home message is that USG guided nerve blocks represents a gold standard in regional anesthesia in present scenario, and it offers an enhanced safety, superior efficacy, a refined patient experience, and mastery requires a deeper understanding of the ultrasound physics, meticulous anatomical knowledge, and disciplined real-time hand-eye coordination. Thank you so much. As we are saying goodbye to 2025 and saying hello to 2026, may God bless us all to achieve all our dreams. Thank you so much.
Thank you, madam. It was a very detailed, in-depth presentation. Thanks a lot. We are just running a little bit late on time. So that's why it was very wonderful presentation, madam.
Thank you so much for giving me the opportunity. Thank you, Priti.
Yes. Now we move ahead with group practice discussion. For this discussion, we call Dr. Balaji Asegaonkar, sir. Sir is a senior consultant. Sir is a senior consultant. He is a consultant cardiac anesthesiologist practicing at Aurangabad. He is director Ozone Anesthesia Group. At present, President San Savli Care Foundation Trust Aurangabad, which is a social service kind of center. We see quite posts on Facebook what kind of good social service work he is doing about. And at present, sir is honorary secretary of Maharashtra State Chapter ISA. He has lots of achievements and awards to his CV. He has successfully handled first heart transplant case at Aurangabad and involved in 20 organ donation at various hospitals at Aurangabad, and 3,000 renal transplants and 5,000 open heart surgery. Sir has membership of many societies like International Anesthesia and Research Society, obviously ISA, member of Indian Society of Cardiothoracic Anesthesia, member of Indian Society of Critical Care Medicine, and many more. Over to you, sir.
Thank you, madam. Thank you for your kind introduction. I will share my screen. Is it visible, madam? Hello?
Yes, sir, visible.
Oh, thank you. Thank you. At the outset, I'm really thankful to Boryoli Society, all my friends, Dr. Rajeshwar Rao, Krupa Singh madam, my friend Tejveer, and Preeti madam, and all the respected members of Boryoli, Shilpa madam, and I'm really thankful to allowing me to talk or inviting me to talk on this group practice in anesthesia. Now, probably many of you heard my presentation on group practice in oration in the conference in Mumbai, recent state conference. Probably more or less the same presentation is there. This is our ozone anesthesia group, and I bring greetings from ozone anesthesia group, Aurangabad. Now it's Chhatrapati Sambhajinagar. We have a 30 full-time consultant, and we are performing almost 30,000 procedures in yearly. And as madam introduced me, we are doing heart transplant to robotics to intensive care unit, and by group we have presented 30 research paper, conducted 4 randomized trial, 4 multi-center studies, 3 national surveys, and we have academy, Ozone Learning Academy, where non-stop from almost now this figure is almost 175 weeks without a single gap. We conducted various academic activities, and all those activities are on YouTube. And we also run a social project, Sneha Savli Care Center. Now, uh, we have our own intubating fibroscope, multiple video laryngoscope, our own ozone office inaugurated by then President Dr. J. Divatia sir, palliative care OPD, then ozone conference hall, website, YouTube channel, and all these things. Now, am I boasting this? No, it's an humble attempt to showcase the potential of the teamwork that we are doing from last 23 years. It is a balanced retrospective view of the group practice, and I'm going to unbiasedly talk about the advantage and disadvantage of the group practice. Now, what do you think in this job? What is the common? Let us first accept that we are in a service industry, and whenever you are in service industry, there are some advantages and some disadvantages. All these are the service industry. The advantages is many times service industry, the success depends on non-technical skill. Maybe you are a very good anesthesiologist, but if you are not good in your soft skill, non-technical skills, you may not get the good success. There is a lot of uncertainty. Means always, even if you are giving best for one hospital, maybe for 10 years, 15 years, and one day something happens and you practice or your association just cut down from that hospital. There is a very high market competition. If there is a supply increases, again, you feel a competition. You feel that people are trying to exploit you. So it depends on the demand supply ratio. So whenever you are working in service industry, the advantages are it's a low initial capital requirement, very easy to establish. You just be sincere and start your practice and you will get established very soon. You got a success very quickly. Then there is autonomy, freedom, not binding. I don't want to do the call today, and it's all right. People will accept that. These are the advantages. The disadvantage, as I already talked, there is a very high market competition. There is a constant performance of pressure. You work for 10 years, 20 years, still people want you to work in the same way. Even a slight laxity on your part and your job may there arise uncertainty to your job. Then time constant. Everyone want to do cases in morning hours, or you have a limited time to work in a day. So you cannot exponentially increase your income. And once you reach the plateau phase, it's very, very difficult to enhance further as far as your income and all those things are concerned. Now, what are the types of anesthesia practice in India? Once you complete the MD, you go for any post graduation or anything like super specialty cardiac anesthesia, pain medicine, or otherwise you directly went into the practice that is a solo anesthesia consultant or freelance practitioner, or you can go to a government job, you can join a corporate hospital, or you can join a group. Now, I will not discuss due to time constraint about the disadvantage of all these things, but I will just focus my talk only on a group practice. Among all models, I feel group practice stand out with a very, very unique advantage. Now, unique advantage to whom? Firstly, to us, to anesthesiologists. When you are in working in a group, there is definitely high chance of work-life balance. You have to work for a certain period of time, and if you are not on call, you will not get a call on that day. There is no stress of work generation. Even if I go for 3 weeks of leaves and I come back from the leaves, and next day I have got multiple calls available for me, because these calls are not for individual, for the groups. Then exposure to a different cases means, being cardiac anesthesiologist, if I would have practiced only cardiac anesthesia, I would have restricted myself to a cardiac anesthesia only. But as I am practicing group, now I practice all sort of anesthesia, right from obstetric to cardiac anesthesia. Whenever there is a difficult case, I go, I try to help my team members. There is a shared responsibility. Suppose something is going wrong, maybe by junior, maybe by senior, immediately your responsibility gets shared. You can groom yourself. You practice in one area of anesthesia, and now you start loving cardiac anesthesia. You can become a cardiac anesthesiologist, because there is a availability of work in the group. And if you take the interest, you can groom yourself into specialty. You can groom yourself into a good academician. You can groom yourself into a research fellow, and there is always opening of leadership role in the group. Now, what group practice advantages offer to the patient? It's always a protocol-based PAC. We ensure that all patients must undergo PAC one day prior, or maybe with appointment with the doctor. Then it offers a better patient safety. Maybe there is a simple call like abscess drainage with mitral stenosis patient. We ensure that 2 anesthetists should go for that call. Or any pediatric patient less than 10 kg, always 2 anesthesiologists go for that. So this patient safety factor is always incurred. Shared expertise and expertise available in the group. Suppose I am not very well versed with that ultrasonography guided block, and I'm only practicing in cardiac anesthesia. If need arises, I have expertise in my group. I can call that person, or I can call him and I give the prop in front of him. He will guide me. Such expertise is readily available in the group. You can discuss the cases, you can discuss the pre-op, you can discuss the complications. So this is a unique advantage group practice offers. To the hospitals, once they give anesthesia department services to you, there is a one-point contact who is managing anesthesia department. There is proper manpower handling. Means there was one day we almost worked from 7 a.m. till 8 p.m. and at night hours there was a organ transplant call we received, and we received the heart, kidney, and liver to the same hospital. Only due to group availability of expert in the group, we could manage the extra amount of manpower. We could provide for those calls, and everyone done these calls very leisurely. So this kind of extra manpower is easily available in the group. It's a very easy billing for the hospitals, and we try to help hospital in their compliances, maybe NABH committee, maybe hospital infection committee. We take actively in part in as a group in that hospital management. As a group, we have got certain other advantage. We have got a better negotiating power. It's less individual exploitation from hospital and surgeon. Surgeon will also think twice before he talks with our juniors, because they know that if they talk irrelevantly with any juniors, we will ask them the questions. Then there is a auto competition, improves the quality of each member in the group. Suppose I am not one of the senior anesthetists who was reluctant to give ultrasonography block, but over a period he realized that everyone in the group is giving USG guided block. So he learned that skill. So this kind of auto competition improves quality at individual level, and there is somebody whom you can share your grievances, somebody whom you can share your whatever sorrow or happiness. This gives a good mental and social help to the group members. Now, are there any disadvantage? Surely yes. There is to some extent there is a pay compromise. Now, why pay compromise? Because group management charges. Managing a group is a very difficult task, and it requires that whatever is coming to the group, it may not be we may not be able to divide it. There occurs a revenue sharing and unequal contribution. Suppose one hospital is paying very good amount for each call. On the contrary, other hospital is not paying that much for the same call. So one who is working in that hospital where there is a good payment, he cannot get a good contribution in the form of paycheck. Means there is some unequal contribution is occurring. There is a huge administrative burden at the senior level to managing the group, managing the call, managing the finances, and is definitely a disadvantage for some people. Then binding of group decisions. Once there is open forum, but it is in the room. Means you can disagree with any point or any decision of the group, but once decision is taken, everyone has to follow the group decision, and this is binding when you are working in a group. There can be hospital and surgeon dissatisfaction about juniors, about way group is working, and there can be intra-group conflicts like ego problem, jealousy, hatred, but we have to be very patient. You have to conquer the ego. You have to be seniors at least. They have to be, must be very humble. They have to be grateful, and they should be compassionate about group members, about surgeons, about hospital. Then and then only group practice works. As in our experience, group practice offers best anesthesia practice model. Here, everyone has got a potential to go on the top position. Whoever is joining the group, he has got a chance to reach the top position maybe after 6 years, 8 years, or 10 years, as per his capability, his commitment to the group. Then you can enjoy numerous collateral advantages, like you have leaves, you have different advantages when you are working in group, and group gives different identity to anesthesia in the society. As far as our group is concerned, now people ask me so many times how to form a group and how to start the group practice. Now the answer is, this is a very, very slow process. It's like sowing the seed, watering, grooming, protecting it over a period of time. And it requires really visionary collective leadership. These three words are very, very important. It's not individuals who can form a group, who can run the group. It's a collective leadership that is required to form group. It's a very slow process, and it's better to have a great team than a team of great. So we always focus on to have a great team. Now, human resource management. When you start formation of group, it requires a few at least ethical and value-owned people. They should believe in a concept of teamwork, and they should align with our vision of the group, and they should not be money-minded. At the time of COVID, we seniors didn't take any penny from the group, and on the contrary, we ensured that all juniors should get their payment regularly. This kind of sacrifice senior has to do when they are working in a group. So the core team must follow this criteria, must meet this criteria, then and then only group practice can be established. Now, what are the financial aspect of group practice? Money collected at one place on one name and distributed as per the seniority, as per the terms and conditions with the group. There is an income pooling, billing practices, and profit sharing model. And there is an incentive scheme. Once somebody works in our group, maybe for 1 year, after 1 year, we start incentive schemes like from number of leaves, everyone get 20, almost 1 month leave, then term insurance, indemnity, health insurance, conveyance allowance, vehicle allowance, gym, yoga, membership, holidays, conference registration. As you become senior, your allowances get increased and you get collateral advantages for working more in the group. Now, there can be a financial problems because hospital may not pay you every month. There can be you might be working with some hospitals who has got a scheme. So group has to keep ready this contingency fund, bank CC, and but group should diversify. It should diversify the income from different hospital. There are administrative expenses, there are extra manpower cost. Means suppose we have 30 members in the group and everyone takes 30 days leaves, means for 900 days in a year, there will be leaves, 900 leaves will be there for the group, means every 3 members will be absent each day. So roughly we have to keep 3 people extra. So this extra manpower cost always decreases payment at individual level. Then we have to spend on group promotional activities, academic activities, and instrumentation like fibroscope and all those things. Now, efficient work allocation. This is a very major area of group practice, distributing calls, distributing people, and its group work allocation is not just dividing tasks, but it's multiplying strength, preparing duty rosters, preparing on-call responsibilities. So the art of assigning work lies in knowing both the job and the person. So senior member must efficiently allocate the work, and that is very, very important. We have a 30 days plus 5 days conference leave, and leaves if not available will be compensated handsomely, and long unpaid leave facility is also available with the group. Now, keeping the quality of our anesthesia, our academics is our responsibility in the group. So it's a continuous journey. We repeatedly arrange training program for our group members. We organize 3 paid workshops, and I'm very happy to share that our all anesthesia team is eco-literate. Everyone can do FATE eco. All members can give USG guided blocks, and we arrange multiple. Even recently, we group has organized airway workshop at Jalgaon, and we all the faculties were from only ozone anesthesia group. This sort of ventures you can do when you work in a group. Then there can be a behavioral problem. I will not go in details of this, but you have to continuously analyze. You have to 360-degree evaluation of each member is must. With this activity we do yearly, where we take the inputs from the sister, from the surgeon, from the colleague, and from himself, that man. So that 360-degree evaluation of each person is done, and whatever problem is there, we try to tell him here the aim is not the fault finding, but it's our aim is to just try to bring him in the in working conditions. So we don't want to find the fault, but we just wanted to correct him over a period of time, and that is why this is. Then excellent through continuous learning, Ozone Learning Academy, as I have already told you, more than 175 activities till date, arranged numerous workshops, conferences, and all these lectures are available on YouTube. It's a free of cost. You become the member of Ozone Learning Academy, and all this access to a huge data you can get through this. We have done a lot of research work. I have already mentioned about this. I will not repeat it. This Dr. Deepak Borde, he is our academic director, and he more than 30 trials and so many randomized clinical trials. I myself has taken so many workshops, even national level. We organized hemodynamic workshops. I have written books on ABG. We have contributed to the ISA. I was the state secretary and president. Then even right now also, our state secretary, city branch secretary from Ozone Anesthesia Group. So we continuously try to contribute to the society. As far as social health of group is concerned, we try to arrange social programs, Diwali get-togethers, we celebrate birthdays, we arrange small trip cricket matches, and this sorts gives connect with the people, with the family, and this gives a different kind of social health to the ozone. Then we have supporting services like administrative staff, monitoring and billing system, legal advisor, and IT system. Our journey of ozone, we started in 2002-3. tried investment in one or two hospital, but it was failure. So we decided that we will never invest in any hospital. From 2015, decided to focus only on anesthesia and ICU services. And over a period of time, we realized that as we are working together, we should do one social work or start NGO. So we in 2018 started one NGO, that is San Sauli Foundation, and purpose of life is not to be happy, but to be useful, compassionate, and make a difference to the life of others. So we started this foundation. This social project is a palliative care unit, and we started with 16 rent or rented premises. Right now we have 55 people. My wife and other group members are actively helping me in this project, and it provides residential nursing care, physiotherapy, excellent food, psychological support, and social rehabilitation. It is like hospice and end of life care also, and it is completely free to the orphans or poor people, and otherwise also very minimally charged. This has given us satisfaction and pleasure beyond work. It has created a great, huge goodwill for the ozone, and for personal level, it is really a fulfilling and enriching experience for me. And this our genuine intention elevated our work to a new dimension. We got a plot by one of my friend who is also anesthesiologist from UK, and we could able to construct 28,000 square feet building, and out of which 10,000 is operation. Right now we have 55 inmates, and we got donations from LIC of India and several corporates to build this building, and main help is from individual donors. So this was the great achievement, I think, for group. And your aim is to every dependent geriatric individual has the right to a dignified life. So no one should be deprived of the basic necessities of human existence. And we are really proud that this social project, Sneh Sauli, is conceptualized by anesthesiologists, run by anesthesiologists, and done by an anesthesiologist. Lastly, alone we are in a drop, but together we are in an ocean. Alone we can do so little, together we can do so much. Ekasya Shakti Alpaha Bhauti Sahanti Tu Mahabalam. Strength of one is small, but when you united in a group, your strength is multifold and it increases immensely. Lastly, as I quoted on that day with his Pasayadan, when we unite, whether as a group or an association, we unlock the power to achieve far greater goals, ensuring that each individual attains what they aspire for. Thank you for inviting me. And I tried to be a bit hurry because I have to complete it in 15 minutes. But thank you very much for patient listening.
Thank you, sir. Thanks a lot. It was a very insightful talk and so much work you are doing as a group. It's very nice to hear. Thank you, sir. Thanks a lot.
Thank you.
Garud, sir. Hello, Garud, sir.
Yes.
सर तुमचं राहिलंय सर.
Oh, yes. Just
हा सर.
two more slides. Hmm. Please allow me to share my screen. I'm not able to share my screen. Previous screen is visible.
सर बालाजी सर तुमचं स्क्रीन स्टॉप करा ना. बालाजी सर स्क्रीन शेअरिंग स्टॉप करा ना.
एक मिनिट करतोय मॅडम. येस.
I think we were at the advantages of PNS guided blocks. It's a simple, compact instrument which we can carry anywhere. I've already told. Cost effective, less expertise is required. Like not like if you compare with USG guided blocks, a lot of training is required, a lot of expertise is required, and equipment is required. Those problems are not with PNS. Then as compared to paresthesia method, anatomical landmarks, this is more accurate, and accuracy is quite high. And most important thing is we always get objective feedback. Like patient cannot cheat us. If there is a current transmitted to nerve, we have to get muscle twitch or twitch response. So this is the most important thing. And if we think about disadvantages of PNS, we need patient's cooperation and patient's tolerance. Like some patients are not tolerant enough. If we increase the current, or if we are not getting the nerve fast and takes some time, patients become restless. They do not cooperate, and we need patients' cooperation. Compared to ultrasound, this problem is not there with ultrasound, and patients usually are cooperative because we don't transmit current, so they do cooperate. Then sometimes being a blind procedure, we don't find nerve easily, so it becomes time consuming. Surgeons sitting on our head, that again prolongs, so, and everybody in OT is restless, so that is a disadvantage. Third thing, it's a blind procedure, so the chances of vascular or nerve injury are high compared to USG guided blocks. And we can use it only for motor or mixed nerves because we need a motor response. Purely sensory nerves cannot be blocked with PNS. Then its accuracy is slightly less than USG guided blocks. And we cannot use this for patients under GA after giving muscle relaxants. As far as safety is concerned, PNS acts as a vital safety tool confirming nerve position when USG visualization is unclear. Sometimes we try to give block under USG guidance, but with technical problems, we are unable to see the nerve clearly. In that case, if we combine USG guided block with PNS guided block, even if we see the nerve and stimulate with the current, it will be double confirmation. It will be 100% guarantee that block will act or we are at the right place. Thank you so much.
Thank you. That's a very elaborative talk. And sometimes whenever the accessibility to USG, we try to do PNS plus USG guided. That is a double confirmation. But
Yes.
for a nursing home and freelancing kind of thing, as you say, we just carry the PNS and then we try to do the blocks, which are a little bit more accurate than anatomical, as the twitch response is visible. Thank you. Thanks a lot, sir.
Thank you so much.
Now we move on to our next speaker. She is a very new and starting her freelancing career, Dr. Marsha Almeida, and she will be talking on the solo practice. She has done BA from Government Medical College, Meerut, DNB from Breach Candy Hospital. She worked as a resident in Breach Candy Hospital up to 2025 Jan, and now she is doing freelancing. She's just starting her footfall in her freelancing. So let's hear from her what are her experiences in all over this year 2025. Welcome, Dr. Marsha.
Thank you, ma'am. Thank you, Preeti ma'am, for that very kind introduction. Good evening to all my senior teachers and colleagues. I am Dr. Marsha D. Almeida, and I will be talking about individual practice in anesthesia. I would like to know whether my screen is visible, ma'am.
Yes, it's visible. but you
Okay.
need to full screen it.
Yes, ma'am. And am I
That's all.
audible?
Yes, very nice.
Okay. Thank you, ma'am. So, like ma'am introduced, I actually have recently started a freelancing practice since the last 1 year. At the outset, I would like to thank BSA group for giving me this opportunity to talk about this topic, especially Dr. Rao sir. Dr. Rao sir has been someone whom I've met right in the beginning before I stepped my foot into exclusive freelancing practice. And meeting him, his mentorship has been very instrumental and useful for me in the last 1 year. Uh, I'm going to share a lot of personal experiences during this talk because, like ma'am said, in the last 1 year, it's just all new for me. So I hope it will be useful for the fellow practitioners who are just starting off their practice. So first, coming to the journey of an individual practitioner, like it has been, and I agree, I assume that our seniors will agree that the first 5 to 7 years, you are very new, very fresh into the market or the field, and you are willing to do any case anywhere at any given point in time and at any charges. As you move forward the next 5 to 7 years, you kind of are grounded in that area, you understand the working dynamics of it, and you gain your foothold there, and then you decide when to work and with whom to work. One important feature at this point is your family priorities are also at its peak, which makes your professional and personal work life balance little challenging, but it is, I agree, fulfilling. The next 15 to 20 years, most of us will be fairly stable and plateaued in our practice. But of course, the fear of competition, especially from groups, will always remain. Now, coming to the key considerations of individual practice, sticking to our basics, pre-anesthesia evaluation is of utmost important in any kind of practice, but especially in individual practice because it kind of lays a base for your work where you are meeting your patients maybe a day prior to the surgery. You are establishing a contact with them, you're discussing the plan of anesthesia, noting about their comorbidities, as well as making of physical examination about their height, weight, how is their airway, or if the patient is for a regional or spinal case, whether it's going to be a difficult or an easy spinal. The most important point about individual practice is that you are a perioperative physician where you're seeing the patient right from the preoperative to the intra-op to the post-op care. So it's like being a part of their journey. The monitoring standards remain same and strict adherence is all to guidelines for monitoring patients under anesthesia. One important challenge in individual practice is emergency preparedness, where you have to have emergency equipments at hand to know the nursing homes or the OTs where you work at, what are the equipments that are available with them. And I think most of us should carry some of the emergency equipments or drugs which may or may not be available just for extra safety, and always having a backup plan. What if your plan A fails? You always need to have a plan B for every surgery. This is why your pre-anesthesia evaluation or visiting the patient 1 day prior, it kind of lays the groundwork for you to have a base on how you are going to take forward the case. And patient selection again of utmost important because you have to know what is the risk criteria of the patient to be able to understand whether you can do the case solo or are you going to need another anesthetist along with you or maybe a backup plan. So for all these things the patient selection is also important. Anesthesia care, no two ways about it. Monitoring is of utmost important. We need to have our ECG, the BP, SpO2 and EtCO2. EtCO2 is now the gold standard and absolutely mandatory for any case, be it a short GA case, a general anesthesia case, or even a sedation case. It definitely helps us take care of the respiration and the saturation of the patient. And to have a decent recovery area, this becomes challenging, especially in nursing homes where the area is small, but we need to have and emphasize on a recovery area where we are monitoring the patient for at least half an hour to 1 hour post-op and only then transferring them to the respective wards. and a safety protocol in which we have an emergency preparedness, and informed consent is of utmost important. Uh, Advisable to take the informed consent 1 day prior when you're visiting after your pre-operative evaluation, to discuss it with the patient and the witness and to take signatures. There will be nothing like it. Guidelines for individual practice, as basic as this slide looks, that we have an anesthesia workstation and the basic equipment. So I have just taken this slide to emphasize how important the anesthesia workstation is also, because I had a colleague of mine who once described an incident in which he was called for a total knee replacement procedure at a small nursing home. And when he entered the operating room, he asked, where is the machine? And they said it is a spinal epidural case, so we can do it with a oxygen cylinder. So there wasn't even a basic Boyle's machine or the basic monitoring that was required for that case. So my entire aim of putting the slide is to understand and probably visit the OT 1 day prior, or whenever you're first starting off at a new nursing home or a new hospital, just to understand what are the logistics, what is available, and what is it that we need to carry or have a backup of. Coming to the benefits of individual practice, like in any this, we have benefits as well as the disadvantages, or more to say the challenges. First, emphasizing on the benefits of individual practice, the most important is that you get a proud pleasure of doing your cases alone. It gives you a sense of accomplishment and a sense of confidence that you can take care of patients single-handedly. You get acknowledged for your cases, and it creates your identity. You are known by your name and the work that you do, as well as it gives you the discretion to select cases, to understand what are your limitations and shortcomings, whether you will be able to do a case single-handedly or no. So these are all benefits that individual practice offers. Coming to the challenges of individual practice, limited resources and backup support. Sometimes you may be working in a single OT kind of a setup in a very small nursing home, and in case there is a situation or a complication, you may not have the option of call for help. So it is always better that you all have known anesthetists around the areas, a good working relationship with them, and who can be there for each other in terms of these emergencies. There is a higher medical legal risk and a personal liability. Difficulty in maintaining work-life balance and avoiding burnouts, being available 24/7, not being able to miss a single phone call, lest that case would have been given to somebody else. So that these are challenges that do come in the way of your individual practice. As well as the biggest challenge is staying updated with latest guidelines and best practices. In an institutional attachment, you have regular case discussions or meetings where we discuss difficult, complicated cases. The biggest advantage of being associated with BSA is that they hold CMEs on a very regular basis and webinars. Physically, we are attending CMEs, even these webinars where we're updating our knowledge, getting known with each other, and sharing our experiences. Yeah, even the WhatsApp group that is being created is very helpful. And all these case discussions, especially for beginners like us, where we understand and read the complications and how well they were managed by our senior colleagues and teachers, eventually is going to help us someday in our practice. Maintaining complex cases with limited team support. Here, the emphasis has always been, and it has been said in many of the webinars as well as the conferences, that we should train our staff, be it a small nursing home, a small hospital, a single OT. The supporting staff that we have, the staff nurses, the technicians, It's important to train them as we go along in helping us in small ways, which actually becomes very important in some kind of complication in a case. They are at least aware of what needs to be done and how they can help us. That definitely helps. As well as for complicated cases, like Sir said, in pediatric cases or geriatric or high risk cases, a difficult airway or difficult spinal, if we can have the support of another fellow anesthesiologist and do it together, the outcome will possibly be better. And the biggest challenge that I faced also starting in in a completely new area was to find centers, to understand which center is safe where we can have a safe anesthesia practice, and our inputs would be taken care of, or to build a relationship with the surgeon, as well as the payment follow-ups. Sometimes there are not timely payments, or there are delays which go over for months. So I think we need to watch out on that only for our financial ups and downs through the months. Coming to the challenges of female anesthesiologists, as all will agree, the all working women would agree that it is very difficult to balance your personal and professional life, more so as mothers. And hats off to each member of this group who is doing such a brilliant work balancing your personal and professional lives. Pardon me for the spelling error. It's about gender bias. There is about a little bit of a racism or gender bias that comes along. Traveling for females from one center to another in a city like Mumbai with so much traffic can be challenging. Odd hours and emergency calls, especially at nights, early mornings, disrupting your daily schedules, it could pose a challenge even more as a female. And unexpected delays. If a surgeon is delayed at a particular case and he comes and arrives late, then your entire schedule for the day gets shifted. So that as well becomes challenging. Work-life balance in individual practice. It's like two sides of the same coin. It's the way we look at it. Uh, it works sometimes for us, as well as being available 24/7 can pose as a challenge and a difficulty as well. So setting clear boundaries and schedules is important. You need to prioritize self-care, take sufficient breaks. I think spare an hour or two on daily basis just for your mental peace and stability. Delegate tasks whenever possible. Staying connected with peers and joining professional networks. This was a brilliant platform that I was introduced to by one of my friends, Sapna, last year. And I'm glad to be a part of this group wherein there are so many academic activities, the recent picnic, as well as these many social events help us to interact and know our fellow colleagues and seniors for our better working. Mentorship. Again, I was fortunate to meet Dr. Rao sir and other members of this group, slowly getting to know even more members who offer guidance on complex cases and career decisions, especially if I've seen a patient preoperatively and I have a high risk case. I usually try to discuss it with a friend or a Rao sir in this group for me to understand how difficult it would be, what would I need to be prepared. There have been a couple of incidences where I've had difficult cases and I'm stuck on table, not knowing what to do next, or a little confused on my next modality or plan of action, in which this phone call definitely helps. Their inputs have been very invaluable in bringing the patient to the post-operative phase. They, of course, provide support and encouragement, share experience and insight, and they help you set and achieve goals. Mitigating medico-legal risks, thorough preoperative assessment and documentation. Hands down, this is the most mandatory, I feel, in our practice, where we see patients preoperatively document and write everything on papers with correct preoperative orders, intra-op notes, and post-operative orders. Ensure informed consent from the patient. One good practice is probably to check the patient identity and the consent before you induce every anesthesia case. Follow established guidelines. Invest in robust equipment and emergency preparedness. Staying updated with CMEs, like I mentioned, these what are held and organized by BSA. and other forums are extremely important for newcomers like us, where we are updated about our knowledge and shared experiences which help us in our day-to-day practice and liability insurance coverage. Mindfulness in anesthesia, as much as they say that it's a very easy job, just giving spinal and probably sitting and chilling, or watching something on your mobile, or during GA, it is a very challenging job in which you have to be alert at every point during the procedure, the critical steps as well as the non-critical ones as well. So mindfulness is absolutely important. Having a good sleep, mental stability is important, which helps us in improve patient care and communication. There is enhanced decision making. We need to have good reflexes and decision making in those few minutes where you have to act in order to prevent a complication. There is reduced stress, burnout, better work-life balance. And how do we achieve mindfulness is basically by yoga, meditation, breathing exercises, or any kind of sports or hobbies. Quality improvement in anesthesia is to develop a evidence-based protocol, have scientific reasons and protocols inculcated in your practice, encourage culture of safety and transparency. Safe anesthesia practice is of utmost importance. Transparency equally important in case you have encountered a difficult airway, or if there has been an anaphylaxis, maybe mild, moderate, or severe. You document, counsel the patient and the relatives so that all these mishaps can be avoided in the future. Provide regular training and education, as BSA is now an IRCF center for COLS and BLS. Uh, Attending these sessions, teaching people somewhere helps us also brush through our basics and engage with patients and family. Thank you.
That was very nice and covering all the topics. Every person who has started the freelancing might have experienced all these difficulties. And with the period and with experience, we try to form a group or little bit of team so that we don't take much stress. टाइटल देना या जीए देना इतना टेंशन लगता नहीं है, जितना टाइम मैनेज करना नेक्स्ट केस पे पहुंचना लगता है आजकल. We can manage any kind of high risk case, but time management, because surgeon might always be late and they will not wait for 5 minutes also. So these are the stressors so which we are now to cope up with and learn. So very nicely covered topic. Thank you, Marsha.
Thank you, ma'am.
So now we move on to the next topic, which is the liquid ventilation. The speaker for the topic is Dr. Nitin Chaudhary. His CV is little bit intimidating. What do I see? How many achievements he has got? He is a assistant professor in New Delhi. He has been recipient of so many awards. Recent one is ISA Delhi Young Research Award 2025, ISA Young Talent National Award 2025. He was university topper in MD examination. He is a state Yuva coordinator for RSACP. He is assistant editor of ISA Delhi newsletter. He has more than 65 publications to his CV, and he has authored 5 book chapters. Welcome, Dr. Nitin. Over to you.
Thank you so much, ma'am, for your kind words. And at the outset, I would like to thank the organizers for giving me this wonderful opportunity. I hope I can do justice to the topic. The speakers previous to me have come out with very pertinent points and very practical things. So the topic might not be very practical in the current scenario, but as we move on, maybe after a couple of years, this might be something that we all may be practicing. But let's see the current evidence we'll be talking about and how this process is all started. So I'll be speaking about liquid ventilation. So just a brief overview of how we are going to go about when we talk about this topic is first the definition, what is the history of liquid ventilation, a talk about the perfluorocarbons, which are the liquids that are used for liquid ventilations. What are the different types of liquid ventilation? What is the mechanism? Why are we wanting to switch over from the gas to the liquids for ventilating our patients, the indications, the adverse effects, the clinical evidence as of now till date. And lastly, I would like to summarize with what the evidence has to say about liquid ventilation in the current scenario. So coming to the definition of liquid ventilation, it is a technique of mechanical ventilation in which lungs are ventilated with an oxygenated fluorocarbon liquid rather than an oxygen-containing mixture. So we do have seen these movies wherein people were, either some scientists, mad scientists, was trying to do some, experiment with a person lying in a liquid tank, and now I think from the time of from movies, now we are actually bringing this in the real world, but this is not something very new. Some of us might feel that liquid ventilation is a relatively new concept, but it is not the case. So let's just delve into its history. So it dates back almost like 40 decades back. So people have tried a lot of liquids, be it saline, be it silicone oils, and PFC were finally the right liquid to go about when you talk about liquid ventilation. It was introduced in the year 1963 by Clark and Gollin, wherein they used liquid ventilation in a spontaneously breathing mice. So the animal studies started somewhere around almost 6 decades back. And it was in the year 1989 that a first clinical trial was done on a human, that is on the preterm neonates, because of the ARDS and the other respiratory complications that are seen with the preterm infants. In the year 1991, Furman and Latchman demonstrated the use of the partial liquid ventilation, and they compared it over the conventional mechanical ventilation. And it was in the year 1993 that Richmond was actually able to demonstrate that there's an improved gaseous exchange and compliance of the lung when you use a PFC model in an animal model. Okay, the PFC model was used in the animals. So we have been doing studies on liquid ventilation. However, if we look into the literature, what the literature has to say before we switch on to what is the current scenario. So what exactly would be an ideal liquid? An ideal liquid should be something, as we all talk about, what is an ideal anesthetic agent or an induction agent? We always talk about something that's very, very, very safe to the human body. So same goes with the liquid. So liquid has to be non-toxic. It has to have a low surface tension so that it does not collapse the alveoli, maintains the patency of the alveoli, can dissolve high levels of oxygen, because it has to eventually transport the oxygen to the humans and also excrete out the carbon dioxide, can eliminate it effectively, has got a minimal systemic absorption, and even if it gets absorbed systematically, it should not have any adverse events, or it does not have any side effects which are fatal to the human body. So it has to be inert as well. Now, when we talk about all these components, they came out with the perfluorocarbons. So perfluorocarbons is the chemical entity which was brought up in the year 1963, wherein they came out with this inert liquid and have been doing random studies, be it from the animal to the human studies, using perfluorocarbons. So it is basically has got two benzyl rings which are attached together. Now, these carbon-bound hydrogen in a perfluorocarbon, as we see the fluoro. So the fluoro is the hydrogen is replaced by fluorine. So then it becomes a perfluorocarbons. And the only perfluorocarbon which is approved by the FDA for only clinical trials, I would like to repeat that, only for the clinical trials. It is not approved as such for a liquid ventilation, but for the sake of going and taking up the trials, be it on the animal studies or the human studies, only liquid is the perfluorocarbon which has been approved by the FDA. It contains one bromide atom, and because of this bromide atom, it becomes radio opaque. So when you try to ventilate a patient using liquid ventilation and you take an X-ray, you will see opacities, or the lung fields become opaque. So you can understand whether the liquid ventilation has really been taken up in the entire lung field or not. So you will get an idea, or any area is still left which is not being ventilated by the liquid. So the radio opacity has got its own pros and cons, which we will subsequently discuss. So the properties should be that it should be colorless, odorless, it should be inert, it should be insoluble in water, can be stored at room temperature, can also be autoclaved or sterilized. The gases should be highly soluble in perfluorocarbons, can dissolve 15 times more oxygen per given volume as compared to plasma, and the oxygen carrying capacity is 3 times that of the blood. And to eliminate carbon dioxide, it can carry almost 4 times more than the oxygen. So what we see is, looking at the outside, this liquid ventilation seems to be a very good entity because it has got a higher oxygen carrying capacity. It can even take off carbon dioxide from the body. It is inert, stable at room temperature. So we do get drawn towards using liquid ventilation and using this particular liquid for ventilating our body. Other entities or the other properties would be the low surface tension, the high density, and it is more dense. So let's compare this with the other liquids that have been used in the past, that is your saline, the air, and the water. So when we look at it, we get drawn towards liquid ventilation because the density is more, the surface tension is the least compared to the other liquids that are available. And also the solubility of oxygen and of carbon dioxide is extremely high as compared to the other liquids. So in the current scenario, when we look at the other available options, a perfluorocarbon is definitely much ahead of all the liquids that are available. So a PFC, an ideal PFC, would have a high solubility, a greater density, a low surface tension, should be volatile, and should be easy to be eliminated from the body, and should also be inert. So how does it work? How does the PFCs, the body reacts to PFC? The pharmacokinetics, if we talk about it, is eliminated by the lungs with the help of volatilization, and a small amount is getting drawn into the systemic circulation, which is very minimal, and that also is excreted out from the skin. So it is absolutely safe when it comes to the human body. The uptake also depend upon the vapor pressure, the permeability coefficient, the solubility, just like any inhalational agent that we talk about. So the same principles would be applicable when you use a liquid for ventilating your body. So all these components will define how much degree of liquid is being absorbed into the systemic circulation. And it can persist in the extra pulmonary tissues for days together. So usually if it's in the blood, it lasts for roughly around 8 days. But in the extra pulmonary tissues, for example, the fat and the muscles, it can last for years together. So that again, although it lasts for years together, but the adverse events as of now have not been noted because of that. So coming to the types, now liquid ventilation can be a total liquid ventilation or a partial liquid ventilation. But let's see, how do they differ? What is the difference between a total liquid ventilation and a partial liquid ventilation? So a total liquid ventilation is when the lungs are filled, the residual volume as well as the FRC is completely filled with the perfluorocarbons. That is, you add the residual volume and also you add the tidal volume that is being added, and it is with each breath, you try to remove the tidal volume amount of liquid from the body. So it's basically just the way you do a gaseous exchange, that a tidal volume is delivered to the patient, and at the time of expiration, the same amount of air or the gas is taken off. The similar way, it's just a liquid which is flowing into your parenchyma or into your alveoli, and depending upon the tidal volume, and the same amount of the liquid will be excreted out, or you can say will be exhaled out at the time of expiration. So that's how it goes about. But it requires a specialized apparatus. The ventilators that we have are not designed to draw and to deliver liquids. They are only for gases. So you require a specialized mechanical ventilator for that. And it is initiated by insufflating the desired volume of the pre-oxygenated perfluorocarbon liquid. That is, the tidal volume and the FRC is filled into the lung. And after that, you would start your ventilation with the liquids. So how will you understand whether the optimum ventilation or oxygenation is taking place? So that will depend upon the adequacy of the minute ventilation. Okay. The rest parameters are absolutely the same. Just the way you do an IE ratio in a normal patient, 1:2, the same principles of ventilation are applicable to liquid ventilation. It does not differ. It is just that in place of the gases, you are just using a liquid, and the tidal volume, the cycles, the breaths, the IE ratio, they are more or less the same. Even the PEEP and would be titrated as per the requirement as you require in normal gaseous ventilation. So it does not differ with respect to that. So that learning part at least is not there, that all the details are different when it compares to the gaseous ventilation. So this is a picture depicting how a liquid ventilation works around. So you can see the lungs on your left side. Now this lung, from if it's been exhaled, okay, and then it goes to a debris filter, because there can be necrotic tissues also, which can also be taken by this liquid. So you have to go by a debris filter. The debris are taken care of. Thereafter, it will again be oxygenated and a heat exchange will be there, so that the optimal temperature of the liquid is maintained. And thereafter, again, through the inhalational pump, the liquid is thrown back into the pulmonary, into the lungs. So this is how it goes about. Just the same way as you do for the gases. The only difference will be, because it's a liquid, it can carry debris along with it. So you need to have a filter, and then obviously you have to oxygenate the PFC before it is again went back into the into the lungs. So how do you wean? So weaning again is a little. It takes time for you to wean. You cannot quickly wean a patient. For example, if I want to wean the patient off liquid ventilation, it cannot be done in a day's time. It has to be a slow process, and you start removing the FRC first, and then the other liquids will also be eliminated with the help of evaporation or the vaporization process. So it will roughly take around a week for you to completely dry out your lungs once you have started your liquid ventilation. So till that time, you will have to slowly wean the patient off. Now, coming to partial liquid ventilation. Now, we talked about the complete, wherein everything was liquid. You had completely filled the lungs with the liquid. But in case of the partial liquid ventilation, what you do is the lungs are only filled with certain amount of fluid. Okay, they are not completely filled, and your gaseous exchange is also taking place. So you have the alveoli, which are partially filled with the perfluorocarbons, and you also have the gases which are driven by a normal gaseous ventilator, which will also take the oxygen into that liquid. So the liquid, there will be an interface, another interface between your alveoli and the gases which are being given to the patient. So that liquid will take up the oxygen from the oxygen that you're delivering through gases, and then it will deliver it at the other end into the capillaries. So that is how it differs when you compare it with the total liquid ventilation. And how do you understand that the partial liquid ventilation, the sufficient amount of fluid has been given to the patient? So once the FRC is reached, you would see a meniscus sign. Okay, so you make the patient, if patient has to be paralyzed and deeply sedated when you're going for a liquid ventilation. You cannot have a spontaneously breathing patient on a liquid ventilation in a human subset. So the patient will be paralyzed. So you make the patient, you let the patient expire. And at the time when the complete expiration is there, you see for a liquid meniscus in your ETT. Okay, if that liquid meniscus is visible, that means your FRC is completely filled with liquid. So only you have to attain the FRC. You would not go beyond FRC when it comes to partial. That is why it's called partial and it's not called as a total liquid ventilation. So you can see here, so the lungs are being ventilated. On the right upper, you can see that the child is connected to a ventilator, and the liquid is being injected in between the system. So you have to constantly keep filling certain amount of liquid in the system before, along with your gaseous exchange. So now the liquid evaporates, as I talked about. So you will have to gradually replace also about 2 to 8 ml per kg in 24 hours is what is the replacement required. And a partial liquid ventilation can be discontinued by ceasing to replace the PFC lost to the evaporation. So the moment you want to wean off the patient, you just stop giving those extra boluses over 24 hours that you're giving to maintain the FRC level of liquid in the body. So after that, in a week's time, the liquid will slowly vaporize and you can have a dry patient, and then you can wean him off the ventilator. So this is how it would look like. If you can see the right upper corner, you see a completely opaque lung field. That is because, as I talked about, because of the bromide in the perfluorocarbons, it is radio opaque, and you can see that the lungs are completely filled with the liquid. Now, how does it act, and why do we want to switch over from the gaseous ventilation to a liquid ventilation? Because of the various properties which are being defined as by the liquid ventilation, which have got a superiority over the gaseous exchange. They are better in terms of the alveolar recruitment, in terms of the VQ matching, the lavage, the anti-inflammatory effects, and temperature regulation. So let's quickly have a insight into how does it act. So coming to the alveolar recruitment, we know that a air-liquid interface compared to a liquid-liquid interface will have a lesser, the liquid will eliminate the surface tension that is there with the air-liquid interface. So the surface tension decreases when you use liquid over a gas. Secondly, the collapsed alveoli are also recruited and stabilized by the hydraulic forces of the liquid. That is another way. The alveoli expansion and the stability is facilitated at lower airway pressures. So the incidence of barotrauma decreases when you give liquid over a gaseous gases. And as more and more alveoli are filled during a part with the PFCs, there will be, and the effective diffusing area will also increase. So you will have an improved oxygenation as well as a compliant. Okay. Coming to the VQ matching, because the liquid is dense compared to the air saline water, so it tends to gravitate down and it will go to the dependent areas of the lung and will help to recruit those dependent areas also. It will improve it by facilitating a gas exchange in the lung liquids that were previously perfused but were not ventilated. Right. So you can have a VQ mismatching because of two reasons. Either the ventilation is better and the perfusion is less, or the perfusion is better but the ventilation is poor. So what it does is, so in the areas where the ventilation was poor, it will go to that area. So the perfusion was already there, but the ventilation was not there. So now when it goes into those areas, so the VQ matching will improve. Secondly, because of the weight, it will go to the dependent zones. And when it will go to the dependent zones, it will redistribute the area, the blood in that area to the less perfused area. So now the areas which were less perfused will become more perfused, but ventilation was already there good, but the perfusion was poor. So that way it will also recruit those areas. So VQ mismatching is avoided, or you can say the percentage is brought down when you go for a liquid as compared to a gas. Lavage helps you to facilitate you to remove the debris and the necrotic material that could be there in the alveoli because of various reasons. Anti-inflammatory, by the mechanism that it attenuates the neutrophil adhesion, activation, and migration. It removes the inflammatory cells and the mediators from the alveolar spaces, and it also acts like a barrier to the intra-alveolar exudation and leukocyte translocation, leading to a reduced intensity of the inflammation and secondary lung injury. So it also helps you to decrease the amount of inflammation in the lung. So if you look at it, it's definitely is a very, very appealing entity, and we do tend to get drawn of going in for a liquid ventilation. And lastly, the temperature regulation, because of it has got a higher heat capacity than the gases, it can help you to have a better heat exchange, and can be used even to warm the lungs and to increase the core body area. Even at the time of when we talk about CPR, post cardiac arrest patients. So we talk about hypothermia. So even for that hypothermia, this liquid ventilation can help you to bring about a decrease in the core temperature if you go for a liquid which is of a lesser temperature. You can go for a cold liquid and it will help you to decrease down the core temperature and help you to have a better outcome in the patients who are post CPR. So what are the indications as of now? So they can be broadly classified as neonatal indications, wherein, as I already talked about, any issues pertaining to respiration, be it a respiratory distress syndrome, meconium aspiration, pulmonary hypertension, congenital diaphragmatic hernia, or a temperature control because of any of the issues, be it hyperthermia or a hypothermia, and lung protection during a CABG. Coming to adults, again, acute respiratory distress syndrome, pneumonia, cancer therapies, for example, you want to give a chemotherapeutic agent, you want it to be equally given to all parts of the lung. So this can be a very good entity, and it also has got a anti-inflammatory action also. Then your drug deliveries can be taken care of if you want something like, for example, you want to give a surfactant, although it also acts more like a surfactant, but still some drug which you want should be given equally in all parts of the lung. It can be a delivery agent, and also for a protection of the lung, donor lung protection also. So nothing comes with adverse effects. Now, the problem is that as of now, we don't see any danger or any severe toxicity because of the PFC, because of the limited data or the limited follow-ups that we have. There are complications which can happen, such as a mucus plug formation, pneumothorax, bleeding complication, hypoxia, hypotension, bradycardia. These things can also happen. But as such, the limited information that we have, it does not seem to be of a tremendous or like a major complication has not been found so far. But still, it is unclear that these side effects which have also enumerated, are they because of the partial liquid ventilation or because of the underlying disease per se? Because these liquid ventilation has actually been used in high-risk patients or the patients who are already severely sick. So we don't know exactly how does it act. Is it because of the underlying disease or was it because of the liquid ventilation? So it can also complicate your certain, it's not easy. It's not that they're all good about liquid ventilation. There are certain bad things about liquid ventilation also, that, for example, the patient's weight should not be, because it is dense. So it increases the patient's weight. And when it comes to giving certain things by the weight of the body, then it can be a confounding factor, especially when it comes to fluid management in your ICU or a critical care patients. Now it is radio opaque. So sometimes you would in a patient who's in ICU, you might be doing frequent chest X-rays to know the condition of the lung, but you cannot do that when you have a liquid ventilation going on, because every time you take a photograph, it's going to be completely opaque. So you don't know whether the lung, the consolidation or whatever etiology, is it in the resolving phase? Is it still progressing? So the radiograph will not be of any use to you. You cannot auscultate because it's liquid. There is no gaseous exchange. There is no gas going in and out, which so you cannot auscultate. You will not hear anything. The impact on the liquid ventilation on the development of the nosocomial pneumonia is still uncertain, and you require deep sedation and paralysis if you are giving liquid ventilation to any patient. So these can complicate your patient management when you're going for a liquid ventilation. So quickly, just the last few slides on the clinical evidence. I've talked so much about how good it is and how lucrative it is, but let's see the current evidence or the evidence as of date with respect to liquid ventilation. So it dates back to 1996, wherein they used the liquid ventilation for premature infants, and they used it in 13 premature, out of which 8 survived and the rest did not survive. So it was very uncertain. So they came out with the conclusion that partial liquid ventilation leads to clinical improvement in survival in some infants with severe respiratory distress who are not predicted to survive. So this generated the curiosity and people wanted to explore it further. So again, in the year 2013, a Cochrane review was done wherein they talked about partial liquid ventilation for prevention of mortality and morbidity in pediatric acute lung injury and ARDS. And they found that there is no evidence from the RCTs to support or refute the use of liquid ventilation in children with acute lung injury or acute or ARDS. And adequately powered and high quality studies are required before we make a final definitive conclusion as to does it have a role or it does not have a role. The problem was that the studies were limited. The studies were of poor quality. Some of the studies were left in between because of the complications that were there in the patient subset. So they could not follow up these patients. So because of this, the studies are also of very poor quality. Again, there was a review, very latest review that came in the year 2020, wherein they talked about neonatal partial liquid ventilation for the treatment and prevention of the bronchopulmonary dysplasia. So they said that it seems to be an interesting entity. It does have a potential role in treatment. However, it is still to be explored, and we need further randomized or high quality studies before we make a definitive conclusion. Now, coming to the effect of PFC or partial on there are more studies. If you look, they are more in the animal than in the human subset, and that is which is more bothersome because we can't really make a definitive conclusion as of now. But this is a recent study again in 2020, wherein they talked about how liquid ventilation can help you to induce hypothermia in dogs with acute lung injury. And the results indicate that mild hypothermia caused by the liquid ventilation can increase the oxygen capacity, can increase the oxygen partial pressure and expression of the anti-inflammatory markers, and improve the lung compliance in dogs with ALI. So these findings do draw us towards giving it a second thought towards going in for a partial liquid ventilation. Another study in the year 2019 came again in the animal subset, wherein they had used partial liquid ventilation, and they said that combined with mild hypothermia, they can provide protection against the ARDS in dogs. Again, a study in 2020 came wherein they used it to study the pulmonary stretch receptor activity using a pulmonary stretch receptor impulse frequency. And they compared the gaseous ventilation with the liquid ventilation, and they found that the peak inspiratory pressures did not vary much when the liquid ventilation was used as compared to gaseous ventilation. So if the lung is stiff, if you don't want to overinflate the lungs, if you know the elasticity of the lung is already absent, if you are going to expand, it's going to do more of damage to the lung than actually helping you to ventilate these patients. So in that context, we can see that the stretch receptor activity is limited or it is not affected when you go for a liquid ventilation as compared to gaseous ventilation. And lastly, we do have some little recent data on on human subjects. It is a case series of 3 patients, which was published in the year very recently in the year 2024 in the critical care medicine, wherein they used partial liquid ventilation in very selected patients, and they found that severe ARDS has high mortality despite the current recommendations, and sometimes other adjuncts and strategies are needed to be considered. And they say that the partial liquid ventilation can be an important tool when it comes to an added adjunct or a strategy wherein the those defined by the guidelines have failed to improve the patients. So these are the patients wherein they had tried everything as per the guidelines. Patients were not at all improving; they were good, they were deteriorating, and as a last resort, they tried to go in for a partial liquid ventilation, and it worked magically in those 3 subset of patients, and they were able to revive those patients and were able to send them back home. So if we look at it in the nutshell, all I can say is that liquid ventilation is an evolving technique. It has been there over the last 6 decades, and with a very limited data, and we still need to explore it. Modifications in the technique have shown promising results, as you can see from the animal studies. The data on the human population is very limited. It has got multiple confounding factors, and these are not well-planned studies. So we need to have randomized controlled trials with a robust methodology before we come to any conclusion of using these partial liquid ventilation in our subset. And however, since we do not have the data, whatever data we have is still plus or minus. So we cannot really refute that partial liquid ventilation is not an entity of any use to us. So we need to have a data, we need to generate the evidence before we either accept it as one of the modalities for our patients or we refute it as one of the modalities. Thank you so much for your patient listening. And once again, I thank the organizer for bringing me here and with such august audience and was able to share my knowledge with all of you. Thank you so much.
Thanks a lot, Dr. Nitin. This liquid ventilation will mostly be useful in ICU setup, right?
Yes, ma'am. Yes, ma'am.
Yeah. So we practice less of ICU, so
yes.
it is more of a theory. But see, it's always better to learn new things.
Yeah, that's why that's why I said that other talks are more practical and they are something that people would look forward to. It will be a very dry topic, but I think it's always good, at least for the PG students. Yeah, they can know something and it can just help them at some point of time.
Thanks a lot for a very insightful talk. Thank you. Thanks a lot.
Thank you so much, ma'am.
Moving on to the further topic. Now we come to our very basic Boyle's machine and workstation. So for the next talk, we have our own Dr. Chandni. Chandni is working as a junior consultant and divisional medical officer at Jagjeevan Ram Railway Hospital. She is attached to the railway hospital since 2018. Chandni was a very much strong pillar in the organization of Yuva Mahakan 2024. We always remember she used to organize our web all meetings, Zoom meetings and web meetings regarding all the planning. So she was a very much key pillar during that. So over to you, Chandni. Chandni.
Good evening, madam. Good evening to everyone. Thank you so much for this opportunity. My name is Dr. Chandni, and I'd like to speak and talk about what I have learned about the Boyle's anesthesia machine so far. So I'm starting my presentation, and I hope I'm visible and audible.
Yes, audible, visible, both.
All right, thank you. So the need for the understanding of a basic Boyle's anesthesia machine in this era of anesthesia workstations, integrated workstations, seems very redundant and old-fashioned. But it may under at present primarily it is used as a strategy for us to pass our exams when we are residents, and we tend to think that we will forget about it and never have to see it again. I have done DNB anesthesiology from a corporate hospital, and this was my understanding when I stepped out after completing my residency. my very first posting at that time was in a peripheral town in Gujarat, and the Boyle's anesthesia machine was the first machine I saw when I was alone in a completely different setup. So that impressed upon me the need to know and to incorporate knowledge of the basic anesthesia machine in our daily practice as well. So this is the picture that started it all, the demonstration of ether. After many years after this demonstration, there was no further advancements which was done. Anesthesia continued to be provided by the drop method, chloroform bottles. There was no mechanism which was primarily used to provide oxygen along with the inhaled anesthetics. So patient deaths primarily resulted due to hypoxia more than any other reason. And there was the semi-open designs also resulted in rebreathing of carbon dioxide and poor oxygenation. There was skin and eye irritation due to the liquid drips. So for many years, the system continued. So primarily before the Boyle's machine, these were the mechanisms of providing anesthesia, and this was the result. The patient safety was primarily based on the expertise of the particular individual providing the anesthetic agent and how experienced they were, how often, how many cases they had seen. And with time, there were improvements primarily used in military field hospitals, small canisters which were brought into use, the Guatemi machine was introduced. They had bulky cylinders, they had manual controls, they caused high pressures and dilution of the anesthetic agents. There was increased risk of barotrauma, and there may have been chances of patient awareness due to this. There was no integrated flow meter, no pressure gauge. There was basically no way to assess how much anesthetic agent was being delivered. It was it was pretty much an eyeball method. There were portable setups. So the need of the hour was a machine that could deliver gases, but also proportionate them and halt flow as and when it was required. Change was introduced when oxygen and nitrous oxide cylinders were introduced and the compressed gases were introduced. And then the first anesthesia machine was developed by the American-made Guatemi-Woolsey apparatus. But this was not patented, although it was produced earlier in 1912. Dr. Henry E.G. Boyle introduced his first anesthesia machine, which was basically a more compressed version of the American machine in 1917. This enabled a reliable continuous flow for delivery of oxygen, nitrous oxide, and ether vapors. And there was a London instrument maker who took up the design of the machine, integrated more features, and made it available for commercial consumption. This machine was in use for many years, even after many more advancements, workstations were developed. The Boyle's design built on prior apparatus and wartime innovations, but it also integrated flow meters, pressure gauges, and valves. So this made a shift from a portable setup to a stationary machine, which was connected to piped gases, which improved patient safety and efficiency. And it helped when surgeries became more and more complex, more and more time consuming. Then many of those components were also introduced, innovated, and refined upon to ensure that there was consistent anesthesia delivery, which were vital for prolonged operation. So this enabled the standardization, and it caused that anesthesia became more of a reliable medical discipline, and it improved upon from an artisanal practice. So what are our core expectations from a basic anesthesia machine? We expected to provide oxygen. We expected to enable patient ventilation. We expected to accurately mix the anesthetic gases and vapors and ensure that there is minimum anesthesia-related risk to patient and to the person who is operating the machine. So these were the principles that necessitated the proper design of an anesthesia machine. So this is a diagram of a basic anesthesia machine. These are available online as well. So although this is the oldest form available, and currently even the older anesthesia machines which are used in peripheral setups may have some modification, this is the basic design of the machine, which is an aluminum mounted trolley with the availability of a hanger yoke assembly for oxygen and nitrous cylinders, with availability for pressure regulators and a back bar with flow meters and vaporizers. Vaporizers, these are the old vaporizers, the boils bottle. There are the systems where they have incorporated vaporizers in circuit, or they have mounted tech vaporizers as well additionally. And the patient outlet. So I'd just like to make a quick go through. We primarily divided into a high pressure, intermediate pressure, and low pressure system. This is just these principles have remained constant despite the fact that multiple innovations have come in through. The high pressure system consists of the hanger yoke assembly, the cylinders wherein high pressures of gases are introduced into the machine, and a pressure gauge which is used for accurate assessment of the pressures. The pressure regulators ensures that the high pressures of oxygen and nitrous oxide are decreased to an intermediate pathway. From there, the pressures will travel through the flow meter assembly, the vaporizer, and through a common gas outlet. There is a availability of an oxygen flush system, which will allow for higher volumes of oxygen to be delivered in case of emergency. So the oxygen flush system is also available. The older anesthesia machines were not fitted in with a ventilator, so they were primarily open systems, and with the incorporation of a carbon dioxide canister, some have been converted to a closed system, but primarily the Boyle's machine is meant for the open circuit system. This is again an overview of the pressure systems which are involved in the anesthesia workstation. This will primarily be of interest when the workstation is discussed. I just included this picture for completion. Now, commonly encountered problems with a Boyle's machine. Boyle's machines are primarily to be used with high degree of vigilance. So vigilance is required from the moment the cylinder is attached to the machine. Although there is a proper pin index safety system, there are diameter index safety system if pipeline connections are available, there is a propensity for a wrongful connection. So manual check has to be ensured before, and we also need to ensure the availability of proper pressure and to ensure proper gas flow in the cylinder. There is no warning system available as there is available in the modern anesthesia workstation. If there is incorrect assembly, it can lead to disconnection of the pipelines, and again a manual check is required for the same. Older machines do not have any oxygen fail-safe devices. The manual whistles and all which were introduced later on. Low flow anesthesia is also not possible in the basic Boyle's machine, as the whole system itself is derived against that possibility. Commonly encountered problems are with the oxygen flush valve. Sometimes this particular oxygen flush valve can get stuck in a particular position. Either it will continue to provide a large flow of oxygen, which can dilute the anesthetic agents, it can over-oxygenate the patient, can cause barotrauma. So it requires immediate leak test. These are some of the troubleshooting methods we can use to check for the proper functioning of the oxygen flush valve, or to make sure we can work it again. Either you can connect the fresh gas outlet or connections, and you can submerge it into water, look for bubbles, or check for leaks in the system by pressurizing it. Can identify wherein the problem is. If it is a worn O-ring, then it requires disassembly and replacement by a biomedical engineer. Primarily how we manage is by, if we are in the middle of the case, is by we increase the fresh gas flow, or we switch the patient over to an ambu bag and separate oxygen cylinder if required. Another problem which we may face is flow meter. Flow meters are mounted, and sometimes what we do is at the end of the case, we may over tighten the flow meters. This can cause a problem with the needle valve mechanism. So gentle opening, gentle closing is always required. And the thought tubes are to be ensured that they are properly functioning. If there is any leak or any break, it has to be replaced at the earliest. If there is a stuck float or the bobbin pin is stuck at some point, we can try and manually flick it with our fingers. But if there is a continuous problem, it is always better to call for proper biomedical engineer to replace or repair. Vaporizer is another problem which we may face, because we at present we use with the boils machine, primarily the Goldman vaporizer is available, but sometimes it is retrofitted with tech vaporizers. Tech vaporizers are agent specific. The ideal way would be to ensure that we use the specific agent in the specific vaporizer machine. Mixing of agents is not really recommended, and there is a risk of inadequate or excessive delivery of the inhalational agent, which may lead to undesired outcomes. There have been reported cases about patient adverse outcome due to incorrect filling of anesthetic agents, and then you cannot really assess the actual volume concentration which is delivered to the patient. So this is a practice which is ideally to be avoided. And sometimes there are fittings which are made without proper biomedical engineering, which is just there are some companies which do indulge in the practice of just connecting one machine to another without understanding the biomechanics behind it or the possible patient adverse events that could happen. So these kind of machines or such kind of companies are to be avoided. If there is requirement for any advancements, it should be ensured that they are done from a reputed firm. There are a few areas where the boils machine is advantageous. It is the primary machine on which we are providing anesthesia. Even modern anesthesia workstations do have components, do have the basic built-up of a boils machine. So knowledge of the boils machine is essential before we can think of working onto an anesthesia workstation. A boils machine is pneumatically driven, it's mechanically driven, it is not dependent on electricity. So it is useful in remote areas where there may be other resource issues. It can also be used in high altitude, as golden vaporizer is not affected by altitude change. Unlike vaporizers, we must calibrate according to the altitude or the height. And there are no delicate parts. It is primarily made of all metal. There is durable. It does not require continuous rigorous maintenance, although due vigilance is always necessary. Disadvantages list is many, and the boils apparatus lacks controlled ventilation system. So we require a manual ventilation unless we can set up a portable ventilator along with it. And there are no fail-safe valves, there are no oxygen proportioning systems. Sometimes there may be a possibility of delivery of a hypoxic gas mixture, so constant vigilance is required. Flow meter flows are pressure dependent, so manual checking of gases is constantly necessary, and there is no scavenging system available with the boils apparatus. In summary, current recommended guidelines clearly state that you require an anesthesia workstation with all the safety features for providing anesthesia to a patient. This is ideal for patient safety. Although in low resource setup, it may be unavoidable, but it is important to remember that all of our modern anesthesia workstations incorporate the basic mechanics of the boils machine. In essence, when you use the boils anesthesia machine, the primary inbuilt safety system is the anesthesiologist. These are my references. Thank you for your time.
Thank you, Chandni. That was a very basic and very in-depth presentation. Thanks a lot. So moving on to the next, we have a workstation. Workstation, we are Dr. Farzeen Qureshi. Dr. Farzeen is my friend since last 14 years. She is consultant anesthesiologist at Wockhardt Hospital. She is MD from Tata Hospital. She has cleared her European Diploma of Intensive Care Medicine. Her special area of interest is critical care, transplant surgery, oncosurgery, and bariatric surgery. Her hobbies are reading and writing literature and poetry. So we welcome you, Farzeen.
Thank you, Dr. Preeti. Dr. Chandni has very well covered the boils machine, which was highly needed because of the forum that we are catering to. I would like to greet everybody with a good evening, and I'm highly honored to be a part of this webinar. So quickly share my screen. If you all can appreciate my screen, Dr. Preeti.
Yes, it's visible. Full screen कर लो. Yeah.
Okay.
Okay.
Okay. So anesthesia workstations, as everybody knows, is the invariable component of our everyday anesthesia care that we are dealing with. And I don't think that any places are without averagely advanced workstation. And if there are places with Boyle's machine, then I think ventilators have been added on. And if not, then the primary anesthetist who's catering to that area will have her own ventilator or her own monitoring system, multi-para monitors, etc., etc., to benefit and to add on to the Boyle's machine to give it the workstation benefit. So overall, I think most of our centers, I wouldn't say all, but most of our centers have lot of advancements in terms of the workstation. So I'll just quickly go through. As we all know that uh, the Boyle's machine history is such that there was everything boils down to this at the end of the day. Basically, that's what I have written. So the Boyle International Continuous Machine, the BOC, which was introduced long ago, it still holds true that the pressure relief systems that it had introduced, including the low pressure, medium pressure, and high pressure, it's still holding true in the modern anesthesia machines. In fact, I would say that the modern anesthesia machines had a very strong base to build up on, because they had the whole sensibility of the inflow, the circuit, and the outflow. It's easier to advance that and to make it more safe. But yes, the structure, the foundation had to be laid, and it has been laid way back. I hope my slide of history ancestry is visible. Dr. Preeti?
Yes, slide visible. Visible.
Okay. So let's go to the next slide. Yeah. So not long ago and still today, anesthesiologists are prominent to what they do best. So what do we do best? We sedate and we ventilate. So Boyle's machine was an invention. It was an advancement over small things like an ether mask, a chloroform handkerchief, an ambu bag ventilation, and many such core techniques. But time and again, we have better and bigger versions coming up in all the arenas of life, and the anesthesia machine is no exception. But now that we have the AI stepping in, the future is vast, unclear, and still with lot of errors and too early to comment on. But yeah, anesthesia models delivering a robotic titrated anesthesia are already doing the rounds in the research centers of the international institutes. So the basic structure of the work machine is integration of a gas delivery, a ventilation, and a monitoring. As you all know, Boyle's machine had no apparatus for ventilation except a open circuit and a manual ventilation. So ventilation per se, the ventilator per se, was an add-on to the basic structure, turning it into an anesthesia workstation. So when we call it a workstation, we assume what all? We assume a small monitoring system, and nowadays including the end-tidal carbon dioxide, which is a basic ASA monitor now, a ventilator, and a gas delivery system. Unlike the previous Boyles, which was not a workstation in inverted commas, it had only a gas delivery system and an added open ventilation with almost no monitoring. So the core system but remains the same. We have the same transition from high pressure to the patient. High pressure is your cylinders, intermittent pressure is your pipeline gases, and the low pressure becomes the flow meters and beyond up to the patient, where the anesthetic vapor is also added. So the basic structure remains very much the same. So what changed? The process of change went into the 5 pillars of in order of the gas flow. So the gas supply, when we had the gas supply, we had the gas supply controlled in such a way that the clinician setting could vary the proportion of the gases actually getting delivered to the patient. And there was no less than 21 to 25% oxygen going to the patient in all cases without exception. The second point, the second pillar of an anesthesia workstation is the advanced technique of vaporization. So you have a selector tech vaporizer. Nowadays, you have the desflurane vaporizer, which is not a selector tech vaporizer, but it is also an advanced calibrated vaporizer. And there are many error preventing methods, the details of which is not possible to touch right now. But the vaporizers are advanced to the precision of 0.01 ml of sevoflurane can also be measured, calculated, and even billed to each patient separately. The third, we come to the breathing circuit. The breathing circuit advancement is definitely the Dragasorb, the soda lime, soda lime absorber, which has been added since time immemorial, but more and more advanced version of it have come up, and the patient is actually rebreathing the humidified and the purified gases through the circle system or the loop system of the ventilation. And definitely you have the mechanical ventilation. Mechanical ventilation has gone up to extremely sophisticated motorized piston with lung protective modes been included. So when you have the critical care patients stepping into your OR, you have a good backup for them to get ventilated at very high pressures, at tremendous amounts of PEEP, and even with lungs full of frothy secretions, you can still ventilate the patient. And you have a lot of variations in the age, respect to the patient's idle body weight, respect to the patient's geriatric and pediatric status. And now you have AI inbuilt devices which are actually calculating how much sevoflurane your patient is individualized to need. So that's the advancement in the mechanical ventilation. And of course, the waste gas scavenging, this is the final pillar. This is for our protection. This is the protection of the humanity and not just of the anesthetist. Any gas that is not inhaled by the patient should be going to the scavenging system, or it should be going back to the patient to get metabolized rather than polluting your OR environment. The waste anesthetic gases have to be vented out to outside atmosphere, have to be prevented from going out to the outside atmosphere, so that the chronic exposure risk and the greenhouse effect of the earth is prevented. So the modern advances, I have enumerated 6 modern advances in the next 6 slides for lucidity. One, we have the closed loop anesthesia. So you have the cognitive load of the anesthetist and increasing patient safety. So that's what the machine is recognizing, that the anesthetist is loaded. It has a lot of information. So what the machine tries to do, it tries to achieve a target for the anesthetist. It tries to think like the anesthetist, and the anesthetist just has to set some numbers on the screen, and the target controlled anesthesia will actually be delivered to the patient with the machine automatically adjusting the gas flows. Second is the lung protective ventilation with the automatic recruitment maneuvers and the high frequency oscillation modes, which were very, very crucial when we were ventilating our COVID patients. And in post-COVID era also, it continues to hold importance. The third one is the AI decision support. AI decision support algorithms are new in the market. There are a lot of errors, like how if you go to a Gemini or if you go to a ChatGPT, 1-2 times you may get the right answer, third time you may not get the right answer. So that is what it holds true even in anesthesia. It may predict risk like intraoperative hypotension, and it may give a bolus dose to the patient. It may predict that the patient may have hypertension because of the incision. It may give a bolus opioid to the patient. But still, the dependency or the blinding of these studies have still to be done based on the based on the future institutes of, mostly India, mostly abroad and less in India. Then we have an advanced gas monitoring system, which I said that you have to go for the very low flow anesthesia. So the fresh gas flows being delivered less, I think, is one of the most important advancements that have changed from the transition from boils to modern anesthesia, that we are polluting the environment lesser and lesser with the modern anesthesia machines. The hypoxic guard, I've mentioned it last, but definitely the most important on the list of the anesthesiologist. We do not want any hypoxia going to our patient at any cost. And that is only possible when the inbuilt systems of the anesthesia machine are working intact and in tandem with your flows. So the oxygen concentration should never fall below 21-25. I think the FiO2 monitor is one of the most important discoveries of the century. So the market leaders, this is nothing to do with any personal choices, but yeah, the GE Healthcare, the Draeger, and the Mindrace have got excellent models of the most modern anesthesia machines. And I wouldn't go into the details. So this is an average anesthesia workstation without the circuits. I've cut out the circuits and the filters, and so that it looks basic. So here you can see it is nothing but your boils machine with the advanced vaporizers and a ventilator with a soda lime for the circle system absorption. And if you see above carefully, you can see a screen. So that screen is nothing but your ventilatory parameters which get monitored because of this inbuilt system of ventilation. Apart from that, you have your hypoxic guards very much in place, and your FiO2 is constantly getting monitored. So in this, you do not have the the ASA monitoring system attached. So that is another addition to the workstation. So that is included, and both of them most of the times may be of some different companies getting blended together. So these are some of the small print booklets which I got, which are just showing, I just copied it here because they are showing the importance of the finer advancements of the very, very newer machines. So you have a heated breathing system, you have a tool-free and quick disassembly of the breathing system, you have an image-guided pre-use checklist. So when we enter the OR in the mornings, we have an image-guided checklist. So even if I'm not able to read, I can see the image and I can check. And unless I pass my checklist every morning, I cannot start my anesthesia workstation. So it's as simple and as direct as that. So there's no question of I didn't check, you didn't check, he didn't check. It will not start unless you don't check. It doesn't start. And if it's checked and there's some leak or there's some issue with the sensor of the oxygen, then it won't function appropriately. So that's how the case gets stopped there and there. So it's like nick a mischief in the bud. It's just there. You don't have to go ahead and then struggle with, intraoperatively that, oh my God, there's some leak here, there's some leak there. If there's no check is not passed, you can't do the case. It's simple. The backup manual mode for manual control in emergency situations is always there in all these machines. The practical hooks, handles, brackets, the tidiness of the machine, the drawers, everything, the wheels, the wheels are so smooth, like in our finger touch, they actually move like a meter front and back. The large touch screen. So touchscreens are very important. I mean, I personally feel that if you are struggling with a critical patient, you wouldn't want to go on rotating the knobs and moving the cursors here and there and wasting time in that when you want to silence an alarm and silence the surgeon also at the same time. So touchscreens go a long way in reducing your stress levels. Obviously, the lockable drawers to, hide all your favorite bougies from the rest of the gang. So this is a Draeger 8-100. This is a 4-year-old model of Draeger, which personally I have not used, but this is the most compact workstation which I have seen. Otherwise, the workstations are quite bulky. This one, which I have introduced here, this has an inbuilt BIS monitor with a lot of neuromonitoring signals, including SSEP and MEP in the same machine. And the breathing systems here I have removed, but you can see the vaporizers are actually installed outside the machine. And also there is a Tiva TCI pump attached just next to the machine. So that's like a real big advancement, that you have all in all one machine. This workstation is definitely what the name is Infinity. And this is the workstation which we are using in our hospital. And this is the Dragger Fabius Plus. So it's a basic model. And we have the inbuilt gas monitoring systems right inside our monitor. And that also it is a four gas. I think it's called a skio patient gas module. So it can detect 4 gases. So if I put on nitrous oxide, which we don't, but if I put on nitrous oxide, oxygen, air, and our inhalational, it can detect all 4 at the same time. And the Dragger advantage is that the ventilator pistons are very efficient. They are one of the most efficient. In fact, even in the critical care, Dragger ventilators are really efficient in ventilating the patient. So that's another advantage of Dragger. So now these are some variations of Dragger which we have found on the net. So this Dragger's Fabius Trio, this is a special machine which can be used nowadays in the high altitude and the low barometric pressures as well. So they have introduced some systematic changes for the specialized environment. And then there is one, the other two I'm not sure of the use, but the last one is an MRI compatible machine, Dragger Fabius MRI, which all the institutes who are catering to should have. I recently heard a talk in BSACon only, in which my guide, Dr. Chiki Rivatia, very confidently said that till we didn't have an MRI machine in the MRI suite of Tata Memorial Hospital, we never gave anesthesia to an MRI patient over there, despite it being such a big institute. We never gave, and it was not very early that we got it. We got it quite late, and only then we could give MRI anesthesia. Otherwise, none of our MRIs were, we never stood cross-handed over there without a machine. So that's something I feel proud of. So yes, there are some cons to it. Dr. Chandni has been really kind to touch upon it. But these machines, they need maintenance. They need skilled maintenance. The electronic and technical dependency is always there. Like if you're running with a power backup, if you don't have a very big generator in your hospital, if you're working in a really resource limited setting, then having these kind bulky machines will be of absolutely no use to you. You'd rather go back to your small boils with your small ventilator. They are bulky, they do not fit for the small ORs, and they give you an overwhelming lot of information. That is one thing which I feel may not be needed for your usual ASA1 cases. So in ASA1 cases, in cases where where you don't really want to know how much the patient's plateau pressure is going to be, or how much the patient is, the negative inspiratory pressure is dipping every time the patient is coming out, there you may feel that all this information is irrelevant. But yes, you do not get to choose. So if it's for A, it has to be for Z. You do not get to choose. And lastly, the eye sees what the mind knows. You have to know what you have to do with those parameters. You have to know what you have to do with the TCI pumps and the advancements and the PEEPs and the valves, the newer things. If you've not upgraded yourself from say isoflurane to sevoflurane, then you would not know what is the exact MAC to be maintained, and then you would land up giving an awareness anesthesia to the patient, or land up doing something more gross. So better to learn well about the workstations, especially your own workstation. There is no option but to familiarize yourself with the working, meet the engineer. I would suggest where the engineers, they are always on a AMC contract, most of these machines. So when the engineers are visiting, take some time to meet the engineer and learn the small technical details, so that in case you're stuck, you're not stuck fully. You know a little bit how to wave your way out through this kind of a storm. And the pro, these are all the cons, and the pro is just one, and it's an enough pro, that anesthesia related mortality has dropped dramatically from approximately 6.4 deaths in 10,000 to fewer than one death in every 2 to 3 lakh anesthetic procedures today. And this, I'm talking about the world statistics, not just India. And this improvement is largely attributed to enhanced monitoring and safety standards that our newer anesthesia workstations have really brought to us. So if you can sleep safely and if you can sleep soundly in the night, it is because someone stepped up and said the boils is not enough and you need something more, something better. So I think we should all go for the upgradation sooner or later, little or more, but definitely upgradation is due. Thank you very much for your time, everybody.
Thank you for the very nice and informative talk on workstation with which we work every day. So with this, we are moving towards our last talk, but it is not the least. It is the very much informative talk. For the next talk, we have our speaker, Dr. Surbhi Jain. She is MBBS from KN Hospital and anesthesia from Tata Memorial Hospital, for which she has got the gold medal, University Rank 1. She has many uh, fellowships, like fellowship in pain management from Sydney, clinical fellowship in anesthesia and ERAS from Glasgow, UK, research fellowship in anesthetic allergy from Sydney, and she is academic visitor for Hospital for Specialty Surgery in New York. And at present, she is attached to Kokilaben Ambani Hospital. She has many publications to her credit, and her main academic interest is CCI, TIVA, ERAS, airway management, and thoracic anesthesia. So over to you, Dr. Surbhi. Hello, Dr. Surbhi.
Is my screen visible?
Not yet. Only you are visible.
Can you just give me a moment?
No problem.
Okay, I'm just going to shut my video off and just try to sort this out. Just give me a Is it visible now?
It was visible, but again,
Is it visible now?
not yet. I got to see for a slide, and then again it is not visible now.
All right, just a minute. So sorry about that, everybody.
It's visible now.
Yeah, all right. Are we good to go?
Yes, we are able to see the first slide.
Yeah. Okay, so sorry about that, everybody, keeping you away from dinner. Right, so at the outset, thank you very much to the organizers, ISA Borivali, SAM's members, Dr. Preeti, Dr. Farzeen for having me here today. It's a great honor to be a part of this webinar, and we've had such distinguished and senior anesthetists contributing, and it's a great pleasure to be here. So the story of anesthesia is one of evolution. And very rightly in the previous talks, we've seen that from the Boyle's machine to the modern workstation. We often think of medical advances in terms of sudden breakthroughs, the discovery of penicillin or the first heart transplant. But in anesthesia, our journey has been a long and deliberate one towards greater patient safety, greater accuracy, and greater precision. The theme tonight is old and new in anesthesia. And we will use this lens to examine one of the techniques that has undergone one of the most significant evolutions, total intravenous anesthesia. For many years, TIVA was regarded by many as a manual, labor-intensive, not very accurate, and risk-prone technique. But today, TIVA and TCI is the new face of modern, personalized, and precise anesthesia. Over this session, we will look at the fundamentals of TIVA, the pharmacokinetic principles that underlie TIVA and TCI, the evolution to target control infusions, and the algorithms that go into it, and how we can use TCIs and TIVA more safely in our clinical scenarios. So to begin with, total intravenous anesthesia is nothing but a technique of general anesthesia, which is exclusively administered through the intravenous route. That means an intravenous drug is used both for induction as well as maintenance. The crucial point here is that no inhalational agents are used, including nitrous oxide. A lot of advantages have been put forth in support of TIVA over volatiles. For me, the most important ones are a significantly reduced incidence of post-operative nausea vomiting, possibly because of the very strong antiemetic effect of propofol. We very well know that PONV is one of the most important patient-reported outcomes, significantly impacting their experience in the perioperative period as well as their readiness for discharge. With TIVA, you also see a much more smoother and a clear-headed recovery, a reduced incidence of emergence delirium, and postoperative agitation. We've also seen topics of OT pollution and the environmental impact of volatiles that is now the hot topic right from our ORs to conference halls. Any anesthetic that requires a general anesthesia can be done using a TIVA technique. Malignant hyperthermia, of course, is an absolute indication. Certain patient factors like muscular dystrophies, a patient with a high risk of PONV, the elderly, patients at a risk of emergence delirium also form a compelling reason to use TIVA. Surgeries involving intraoperative neuromonitoring, neurosurgery, also has advantages when TIVA is used, as volatiles can significantly impact evoked potential readings. Also, because the technique of delivering the anesthetic is separated from the airway, it is very useful when airway surgery is being performed or when you're sharing the airway. A various combination of drugs has been described for the use of TIVA, both opioid-based as well as opioid-free. For the purpose of this talk, we will stick to the combination of propofol and remifentanil while describing our discussions. So, traditionally, we've used TIVA either in a bolus dosing method or as a manually controlled infusion, perhaps through an IV drip or through an infusion pump. More recently, we have automated infusions such as target control infusions available, and now closed-loop anesthesia delivery systems or CLADs that are developed in India as well by Dr. G.D. Puri at PGI Chandigarh and are available for use. So before we dive further into the world of TIVA and TCI, it is important to understand the basic relevant pharmacokinetic principles. We begin with the three-compartment model. Now, the three-compartment model is a mathematical model that has been described to show the movement of an intravenous drug through the body. It shows the relationship of your initial bolus dose and the various compartments in the body and the effect at the effect site, which is the brain. So when you administer a dose of a drug like propofol, there is a sharp increase in the concentration of V1, which is the central compartment, which consists of blood or plasma and rapidly perfused organs like the brain and the lungs. Now, from V1, this drug is getting distributed to and redistributed from two peripheral compartments. The rapidly perfused V2, consisting mainly of muscle, and the much larger, slowly perfused V3 compartment, consisting mainly of fat. Now, because every anesthetic drug needs to be lipophilic in order to cross over the blood-brain barrier, it will also get distributed to and redistributed to these compartments. So at steady state, the volume of distribution is the sum of V1, V2, and V3. The rate constants K describe the drug movement between these compartments. The rate constant KEO is an important rate constant and describes the transfer between the V1 and the effect site, which is the brain. Let us look at this once again. So when you start a drug infusion, the central compartment of V1 gets rapidly filled up. There is elimination happening. At the same time, drug starts moving to the two peripheral compartments, V2 and V3, because of the concentration gradient. The concentration in V2 will rise a little bit more rapidly because it's more rapidly perfused. As it starts getting saturated, the rate of increase will start going down. There is a slow, constant perfusion to V3. Now, at steady state, which is at 25 hours of propofol infusion, there is no drug movement happening between these three compartments because the compartments are saturated. When you stop the infusion, there is going to be a sharp decline in the concentration in the plasma because of elimination. Because of the concentration gradient that has been established, there will be drug redistribution from V2 and a slow drug redistribution from V3. This is the reason why we have a hangover effect, because there is propofol redistribution from the fat over a long period of time. The next important concept is context-sensitive half-life. Now, we as anesthetists deal with a very different level of pharmacology. At the end of my surgery, what I am interested in is how quickly is my patient going to wake up? That is, how quickly is the drug concentration going to fall below 50% or less, allowing my patient to wake up? The elimination half-life of the drugs that we commonly use ranges from minutes to hours. A more relevant concept for us is the context-sensitive half-life. This, by definition, is the time required for the plasma drug concentration to decline by 50% or less after terminating a drug infusion. So this is what governs the choice of our drugs used in an infusion. So what do we mean? When we talk about propofol, when we run a prolonged infusion and stop it, the context-sensitive half-life is 30 minutes or less. That means when we stop the infusion, it will take 30 minutes or so for the plasma concentration to halve. The same is for sufentanil. Now, in the case of drugs like fentanyl, it has a very steep curve. That means that even after a very short duration of a fentanyl infusion, on stopping, the time that it will take for fentanyl concentration to drop is going to be very high. Now, in contrast, remifentanil has a linear and flat slope. That means that it is context insensitive. Irrespective of when you stop the infusion, the patient's concentration in the plasma is going to fall in less than 5 minutes. And that is the beauty of this drug. So, through all these times, we've done many cases using this, known as the Bristol or the Roberts regimen, where we use TIVA manually through an infusion pump. We do so by using an induction dose of 1 to 2 milligrams per kg and immediately starting a maintenance dose using 10 milligrams per kg per hour for the first 10 minutes. We then step it down to 8 milligrams per kg per hour for the next 10 minutes, followed by 6 milligrams for maintenance. This is also known as the 10-8-6 rule. So let's address the elephant in the room. We've done thousands of cases using manual TIVA methods. We've used infusions, we've used boluses, and we've successfully completed them. But a successful outcome doesn't necessarily mean the most optimal outcome. What do I mean by that? So let us look at when we are using an intermittent bolus regimen. So we give a we are giving a bolus dose. We cause a sharp increase in the plasma concentration of the drug. The level starts falling. We react to the patient's response, say the patient starts moving, or we think that the patient will require a greater depth, and we give another bolus. The cycle repeats. So we see this sawtooth pattern with an intermittent bolus regimen, a roller coaster ride where we're doing guesswork and reacting. We're doing reactive anesthesia. Now let's compare that to when we are using a continuous infusion regimen. Now, as we know that initially the drug is going to reach the V1, the central compartment, and there will be a delay as the concentration rises and reaches the effect site, the brain. So that means during this period, there is an inherent lag where we might experience either a risk of underdosing, and sometimes when we maintain this continuously for long hours, a risk of overdosing. So that means, say you're running a surgery for 8 hours, you're in a spine surgery, you're doing guesswork. After a few hours, you're thinking, okay, maybe now the tanks or the tissues are saturated. Let me step down the infusion rate. But we don't really know what exactly is happening. The plasma is still saturated with the drug. And that is why the patient takes a longer time to wake up or has a hungover effect, so to speak. This is what led to the development of target control infusions. This is a real paradigm shift in the way we fundamentally think about drug delivery. We no longer think in terms of dose, milligrams per kg. We are now targeting concentration that we desire directly in the plasma or now at the effect site, which is the brain. So what is a TCI? A TCI is nothing but a computer-controlled infusion system, which precisely regulates the drug delivery and maintains this desired depth of anesthesia. It is based on accurate modeling of the drug's pharmacokinetics and calculates the infusion rates to achieve this target concentration in the blood. It automates the math. You simply have to sit back and relax and be on cruise control. It is the pump that will calculate what is the infusion rate that is necessary after certain amount of period for that particular patient and adjusts the rate continuously. We do not deliver any bolus dose, we do not determine what is the rate at which the infusion is going to get administered. The TCI pump does that all for us, much akin to a modern cruise control. So they come in all shapes and sizes from various manufacturers in the Indian market. All of them consist of a fundamental three-part architecture. It consists of a pump, which is the hardware, the infusion syringe driver, which is going to help you to deliver the drug. It consists of the pharmacokinetic model and the TCI algorithm that is going to use the input data, the covariates that you enter, and the target that you set. This will tell the pump at which rate and how the infusion has to be delivered to the patient. And a very simple user interface, which consists of either toggle buttons or a touch screen. It's fairly intuitive and easy to use. Before we move further, there's another concept that we need to understand before we start using a TCI pump. And this is whether we are using it as a plasma targeting model or an effect site model. So when we talk about plasma targeting, we are essentially telling the pump that the concentration that we are targeting, the number that we are entering, is the concentration that we desire in the plasma. So the pump is never going to overshoot this set target. So even though your plasma concentration will increase and match your target, you will see an inherent lag as the concentration at the effect site is still catching up. Hence, it has a slow onset and a slow offset. Let's compare that to an effect site model. So when we use an effect site model, we are telling the pump that we want the set concentration to be directly at the brain, the effect site. So to do so, what the machine does it delivers a higher initial loading dose to saturate the central compartment. Now this creates a pressurizing effect, causing the drug to move more rapidly into the brain, and you see the onset of response much more quickly. Hence, it has a quick onset and a quick offset, and is good for rapidly titrating according to the needs of the surgery. Of course, it comes with its pharmacodynamic effects because of its higher initial loading dose. So let's see how the pump works that out. As an example, so when we are using an effect site targeted target control infusion, at time 0, we decide that we want a concentration of 3 at the effect site. So what the pump will do, which is the blue line, is it will give a sharp high bolus and it will stop bolusing. Now this will cause an increase in the plasma concentration, which is the red line, causing the drug to move into the brain because of the concentration gradient. And as the concentration gradient, as the effect site concentration increases and matches the target that you've set, the plasma concentration will start dropping. Now at 5 minutes, you decide to change it to 6. So once again, the infusion pump gives a bolus. You are not delivering a bolus, you are only increasing your target. The bolus is delivered by the pump. Again, a rapid increase in the plasma concentration, driving the drug into the brain, increasing your effect site concentration till you make your next change. Now, at 10 minutes, you decide to once again make the concentration 3. The surgery is coming to an end. You want to taper down. So this pump stops infusing. There is no background infusion rate. The plasma concentration starts falling because elimination is still happening. This once again creates a gradient in the opposite direction, causing drug movement from the effect site into the plasma, and then it slowly matches the reduced target that you've set. And this continues. The infusion pump calculates a background infusion rate to match the target that you have set till you make the next change. So we've heard a plethora of names, and we often get daunted by the number of TCI models that are available, but they are fairly simple. So we'll very briefly touch upon the ones that are relevant to us and that we commonly see in our pumps. So we begin with the Marsh model. This is the original model that was first used in the commercial TCI pump dip refuser. I've had the good fortune to work in the very same institute where the MARSH model was developed by Professor Kenny, and that was in Glasgow. So the crux of the MARSH model, the genius and its limitation is that it uses total body weight as its scaling parameter. So it follows that it considers the V1 or the central compartment to be quite large and hence delivers a larger initial bolus. Age is not incorporated into the calculations and it uses fixed rate constants for elimination. So it follows that because of the larger initial bolus, it can lead to hypotension in the vulnerable population such as the elderly and the frail. It is the most widely validated and familiar model used across the world and works very well for your average young healthy patient. The Schneider model was then developed to address the limitation of the Marsh model. Now, this accepts age, height, weight, and gender as its covariates and calculates the lean body mass, which it uses for its scaling. It has a small and fixed V1, hence, it has a smaller initial loading dose. It also incorporates age adjusted clearance. So, it is a model of choice when you're using it in elderly or frail patients. Very recently, we now have the Elevate model developed by the who's who of the TIVA world. This was developed as a general all-purpose model with the aim of eliminating the need for the clinician to think about which model needs to be used for the next patient on his table. This was based on a massive meta-analysis, over 30 studies and over 15,000 data points. It has been validated for use in neonates as well as the elderly, from the lean to the super obese. It uses non-linear allometric scaling. A very elegant feature of the Elevate model is also that it accounts for opioid and hypnotic agent synergy. We actually can enter whether we are using an opioid or not into the system, and it uses this information to calculate and maintain lower infusion rates. Pediatric TCI models are available. Marsh model has not been validated for less than 16 years of age. Ped-Fusier and the Kataria regimens have been traditionally used in the pediatric age group. These are both plasma-targeted models. The Elevate model is now available for use for pediatrics and has been well validated right from neonates to the elderly. When we come to the other arm of TIVA, the opioid, the Minto model is the most widely implemented TCI model for remifentanil. It was specifically designed to manage the unique metabolism of remifentanil, i.e., its plasma esterase breakdown. It also uses age, weight, height, and gender as its covariates and scales to lean body weight. It allows for very precise titration to rapidly changing needs. So, armed with this knowledge, we as an anesthetist can use the TCI quite easily. We have a good knowledge of the pharmacological models, the therapeutic windows of the drugs that we are using, and the effects that the covariates have on the patient disposition. We now select the appropriate pharmacokinetic model, input these covariates, choose whether we want to do an effect site targeting or plasma targeting, and designate our target concentration. We now monitor our patient continuously using clinical signs, hemodynamic parameters, and processed EEG monitoring to help us titrate these targets. So how does that look in the real world? So setting up for TIVA is like setting up for any of your general anesthesia case. All standard monitors, all emergency drugs, all airway equipment, multimodal and regional analgesia as you practice it. There are various safety checklists available for TIVA. Use dedicated TCI pumps when available. This has been recommended by the Royal College of Anesthetists for whenever propofol is being used as the TIVA drug. Always make sure they're plugged into mains and the batteries are charged. The most critical error that happens is incorrect drug dilution or loading. So that is a key area to focus on. We select the correct drug, patient details, and PK model. It is recommended to use processed EEG monitoring, especially if muscle relaxants are being used. Now, it is recommended to have 2 IV accesses and 1 exclusively for your TCI lines. Whenever practical, have them visible. Anti-siphon valve on the drug delivery line and anti-reflux valve on the fluid line has been recommended. These are not very readily available in India. Always set up with IV fluids. Vigilance is key. There are many aids to and mnemonics to help you set up your TCI pumps and minimize errors. This is just one of them available from the NHS. So let's see how easy it is to use the TCI pump. This looks just like your regular infusion pump. It just has a software upgrade. So we are programming our remifentanil pump and our propofol pump. This is before the patient is being wheeled in. We are setting up. So with the remifentanil, we've selected the TCI mode. We've selected the Minto model. We are entering the age. The user interface is pretty easy to use and intuitive. You just enter your parameters, the correct parameters. And for propofol, we've selected the MARSH model, a plasma targeting model in this case, and we've selected a target concentration of 4 over here. Okay. It gives us prompts, it gives us error alarms, and we've set our targets and we are good to go. So the patient has been wheeled in now. We are attaching the monitors. We've attached the lines, the infusion lines to the patient. As we are doing the sign-in, we start our pump. So the CPT over here is the target that you have set. It's 2 for Remi at the moment and 4 for propofol. The CP is the plasma concentration. And you can see that it is now matching. It has increased and is matching the target that you've set. Now, when I titrate it upwards, I've set the concentration to 3. The plasma concentration is rising. And you can see that over here, this is CE, the effect site concentration. This is going to catch up. This is the lag, the hysteresis that I was talking about. So even though your plasma concentration is matching your target concentration, your effect site concentration is going to lag behind a little bit. So the patient has now lost response to verbal commands and you're ready for your intubation. So as the case progresses, you're in the maintenance phase. You're using your clinical parameters, your hemodynamic variables, your BIS values to titrate your drugs down. So now when I reduce my propofol concentration to 3 from 6, the pump stops infusing. And because of this concentration gradient, the effect site concentration will slowly start to fall. As we prepare for emergence, we simply turn the targets to 0. We don't switch off the pumps. The pumps give us very valuable information of decrement time or the time to wake up, where we can very precisely understand how many minutes it's going to take for the patient to wake up. Now, the patient has started breathing spontaneously. The hemodynamic variables are stable. And very soon at a near value of about 1, less than 1, the patient is going to open his eyes. So there are these tables that you will often see while reading about TIVA and TCI, and they hold true. So for surgical anesthesia and intubation, a TCI dose, a target of 4 is recommended. And while using TIVA, 10 milligram per kg per hour is what we've been used to. Similarly, for remifentanil, the target of 3 to 6 has been recommended. Now, a word of caution over there. In my experience with Indian patients, they're very sensitive to remifentanil and you often need a much lower dose than these recommended. So just titrate to your effect and go start with a lower dose, and then you can always increase it with a very rapid effect because of its short peak, onset of action. So just a pointer as to how you can do a TCI anesthesia. So when you are starting, you use a target of 4 to 6 for propofol and 6 to 8 or maybe 4 to 6 for your Remi. After intubation and the patient has settled down, you decrease it to 3 to 4 for propofol. During maintenance phase, you use 2 to 4. And as your emerging, as you're going to you're moving towards the end of surgery, you shut your propofol infusion to 0. Now, with remifentanil, you can use anywhere from 3 to 12 as your target. In the Indian population, it's much lower. They do very well with concentrations as low as 1.5, 2, and 3. Very barely have I gone up over 6. Now, with remifentanil, we must remember that it has a very, very short half-life. The action is going to end almost as soon as you switch it off, and there's always a risk of opioid-induced hyperalgesia. So to counteract that, you have to have multimodal analgesia in place. You can use a long-acting opioid like morphine, if available, or fentanyl 15 to 20 minutes before you're going to switch off your remifentanil. This takes care of the analgesia in the immediate waking up period. Similarly, you have similar regimen while using a TIVA non-TCI way, where you use the Bristol regimen for propofol and you use 0.25 to 0.5 microgram per kg per minute of remifentanil. So why is TIVA and why is TCI not the gold standard? Why are we still preferring volatiles as the universal general anesthetic? Obviously, the first and foremost barrier is the equipment and the cost it entails. We have very limited access to TCI pumps. Remifentanil up till very recently was not available in India. And we always have a malfunction risk because of the technology that we are using. There's also an aversion to change. People have been using this for decades, and there is this inertia to adopt a new technology when this has been working fine. And there is people get daunted by the pharmacokinetics or the model names of TCIs, and that sometimes acts as a hindrance. Vigilance is key, as is the case in all cases, and it is recommended to use depth of anesthesia monitoring, which adds to the cost. So I know that I'm speaking to a forum where the vast majority are to private practice and freelance practice. So in my opinion, in the case of, say, hospitals, we can talk about the economics of precision. The direct versus the indirect cost, not just the cost to the pharmacy, not just the upfront cost of the TCI pump, but also the savings that happen because of the reduced reliance on the PACU nurses for managing PONV, lesser antiemetics use, a faster discharge, a higher operating room and PACU throughput, and reduced waste. So in the long picture, the gain is actually towards using TCI and TIVA, because every few minutes in a heavy caseload lists increases your work output and the gains that you have. For the private, as was very well spoken in the talk on private practice, on creating your identity, I think for freelancers, you are the brand. You are the anesthetist that causes the fastest wake up of your patient. The patient often says that laga hi nahi ki surgery hui hai. You will have lesser phone calls for managing PONV or drowsiness in the PACU, and you'll be able to reach your next case much faster. And that's just what I feel. So as we conclude, we are now standing at the brink of completely automated anesthesia. We already have the CLAD system in place, which is constantly getting upgraded. We have moved from beginning in the dose domain, where we simply calculated the dose in milligram per kg and pushed the syringe, not knowing what actually happens to the patient, to the concentration domain with the advent of the TCI, where we started thinking in a more scientific way about what is the concentration of the drug that we desire in that particular patient. But is that the final destination? No. What concentration is enough for the patient on your table right now might be too little or too much for your next. So it is not truly the concentration that you're targeting. You want to target and control the clinical response or the effect. This has led to the development of closed-loop anesthesia systems, the ultimate paradigm shift. So from controlling the input, the dose, we have come a long way to controlling the output, which is the effect. Imagine you're standing in an OR where the patient's parameters are not just being monitored, but they are being intelligently integrated and dynamically managed by advanced AI. This future is taking shape. It is actually right now and right here, and we are fortunate to be a part of this change. Thank you so much for your time and your patient hearing. Thank you.
Thanks a lot, Dr. Surabhi. I must say and congratulate your presentation was so nice. I was feeling, see, I'm watching some high sci-fi movie, and the way you present was so nice. It's a very nice, informative, visually good, and audible presentation. Thanks a lot.
Thank you so much, and apologies for the initial bit.
That is technical glitches we all have.
Thank you so much for your kind words.
Yeah. Thank you, I say Borivali, Rajesh Rao sir, Dr. Krupa, Dr. Sandeep, to give me the opportunity. Now I call upon our honorary secretary, Dr. Krupa, to say a vote of thanks.
Thank you all, the speakers, for giving us the opportunity and the platform. And the way they have all spoken is very nice. They're up to the mark. Not one of any one of had felt that this. Some of them are first-time speakers. Thank you, Jenica, for providing us platform for conducting this opportunity. Thank you, Preeti, for moderating this session. She has done a very nice job. In spite of giving her less time, she has done wonderful job, and she has got all the speakers ready within very less time. Thanks, Preeti, and thanks, ISA Burivali, for giving us an opportunity. Thank you all. Thank you all the delegates to listening patiently. This idea of old versus new came from one of the senior most anesthesiologists from the ISA Borivali branch. This webinar has given an insight. Whatever what we were practicing in old timers still holds true. We should know what we have done previously, what our previous generation has done. It still holds true in this some private nursing home scenario. We can still go back in times, and we have to do what they have done since long, but we also need to upgrade ourselves with newer technologies, so that we can inculcate all that in our practice and go ahead and move to safe anesthesia and safe practice for the safety of the patient. Thank you all for patient listening.